So good morning to you all. I'd like to welcome you to the Public Health and Prevention Cabinet panel meeting. I'd like to welcome members and officers and any public that are listening. I'd like to explain, I'm not your normal chairman, as you know. Tim has had an operation on Monday on his shoulder. He was hoping to be able to chair the meeting, but this morning I think the anaesthetic had kicked in a bit, and so he asked whether I would take the meeting for him. So I will do my best for you all. So to start with, I have a formal announcement, and due to the coronavirus pandemic, the Council will be holding this meeting electronically in accordance with the relevant regulations. Members of the public may also attend this meeting in an electronic capacity, and there's a link on the Council's website for them to do so. Members of the Council are asked to keep their microphones switched off until called to speak, and to switch their microphones off once they're finished speaking. Cameras may be left on throughout the meeting if members wish. If you experience connection or other technical issues, and I know Caroline might have one, it may help to switch your camera off. Cameras should be switched off if and when speaking in the meeting, switched on rather. To indicate a wish to speak, members should use the raised hand function. Use of the meeting chat function is exclusively for voting. At the end of the debate on each item of business, there will be a vote, and members are asked to use the chat function and indicate for, against, or abstain, and I'll declare the result after each vote. If we go beyond 2 hours, which I'm not sure you want to do, but we'll find a suitable break for us to have a 15-minute coffee rest. So if I continue on, substitutions. Do we have any substitutions, please? I take that we don't. Don't have any word for an officer. Is there an officer there?
Yeah, Annie, there's no substitutions.
Okay, thank you. And no apologies, therefore. Right. So I'm going to ask each member to introduce themselves. I'll just say your first name, but if you'd be kind enough to give your full title and the division that you represent. So I'm Annie Brewster. I'm vice chair of this panel, but today stepping up as chair, and I represent Harpenden Rural. So may I ask Lynn, please?
Thank you, Chair. I'm Lynn Chesterman and I represent Welwyn Garden City South. Thank you.
Thank you. And Caroline?
Good morning, Chair. My name is Caroline Clapper and I represent Watling Division, which covers Radlett, Alderham and Elstree. Thank you.
Thank you, Caroline. Margaret?
Hello, I'm Margaret Eames-Peterson and I represent Hatfield North Division.
Lovely, thank you. Susie?
Good morning, I'm Susie Gordon. I represent Hatfield East.
Thank you. Fiona? I think that's it. Thank you.
I'll unmute myself. I'm Fiona Guest. I represent Hemel Hempstead North West. I'm a pharmacist by profession and my application to become a COVID vaccinator has gone through with my first shift booked in Aylesbury for the 25th of Feb.
That's marvellous. We're very proud of you, Fiona. Splendid. Well done. Thank you. Tina?
Good morning, Chair. I'm Tina Howard and I represent Hemel Hempstead South East. Thank you.
Thank you, Tina. Mark?
Yes, good morning, Chairman. Good morning, everyone. Mark Mills Bishop, Conservative member of this panel, and I represent Plumstead End and Turnford Division. Thank you, Chairman.
Thank you, Mark. Nigel?
Yeah, good morning. I'm Nigel Quinton. I'm the Lib Dem councillor for Hanside and Pear Tree in Welwyn Garden City. I just realised almost all my neighbours are here. Annie, Lynn and Margaret.
Oh, we've got a tight pincer movement going on, Nigel. Excellent, thank you. Anthony, have we got Anthony?
You have indeed. You've got me in voice, but not in camera. My camera seems not to be working again. Anthony Rowlands, County Council of St Albans East, and I don't have any neighbours present.
Okay, thank you. And Anthony's already apologised. He has to leave a little bit early for a funeral. So, Anthony, just go when you need to. Thank you. Ron?
Yeah, Ron Tyndall, Liberal Democrat, councillor for Hemel Hempstead St Paul's. I've actually just volunteered to be a community mythbuster for the vaccination team. So I have no idea what I've got to do yet, but we'll see. And also, I would please, could you pass on all our good wishes to Tim for a speedy recovery, please?
Yes, will do. He can't do any knitting for a while, apparently. So it's yeah.
He's okay on the crocheting, though, is he?
He's on crocheting, no sequins. And finally, William, please.
William Whitelow, County Councillor for Hemel Hempstead Town.
Thank you very much, William. So just a little note on members' interests. Members are advised that in respect of the debate concerning the Council's integrated plan, including the setting of the Council tax precept, the Standards Committee has exercised its power to grant a dispensation to all Hertfordshire County councillors for the requirement to declare a disclosable pecuniary interest or a declarable interest. So accordingly, there's no requirement for any councillor to make any declaration of interest in respect of this item of business. But members are reminded that Section 106 of the Local Government Finance Act 1992 provides that if a member is in arrears of council tax for 2 months or more, and they are present at a meeting where the council's budget or the precept is being considered, then they should declare this, and any such member must not vote on any matter relating to the setting of the council's budget or the precept. The provision of S106 of the Local Government Finance Act 1992 applies even if there is an arrangement to pay off the arrears. Well, I'm assuming that doesn't apply to any of the members on this committee, so we will carry on. So may we go to the minutes, please? And I've got a couple of updates on the minutes since they were sent out. The first one is on item 5 on page 8, which was covering the housing support and complex needs. And Natasha Welsh has sent a message to say, we're still awaiting confirmation from the MHCLG as to whether the shorter term aspect of the funding is set to continue beyond the 31st of March 2021. And we're in the process of compiling the information from the districts as what they applied for, and I'm hoping that this will be available for sharing soon. I'm sure she'll share it with members as soon as she knows that. Then on item 6 on page 9, Natasha circulated the information in relation to the sustainability item following our last panel, so I hope you all managed to get that. So with those updates, may I have a view, are all members happy to note the minutes? And I do need a vote for this. So if you're able to vote in chat, or please put your hand up if there's anything you want to speak on. No, okay, so would you like to vote in chat if you agree? Thank you. Okay, that looks unanimous. Am I happy? Are you happy, officers? I just carry on? Yes? Good, thank you very much. So item 2, public petitions. We don't have any this morning. So we'll move on to item 3, which is on the agenda pack, page 13. And this is our integrated plan 21-22 to 24-25. And we have Joanne Doggett, Head of Programme Delivery and Service. Jo, you're here this morning and you're going to speak on this item. Thank you, Jo.
Yes, good morning, everyone. Hi. OK, so the IP cover paper was put together by our corporate finance colleagues. It's a standard template that goes to all of the different panels. And any detailed questions about that will need to be directed to Stephen Pillsworth, one of our finance colleagues. I'd like to focus today, if possible, on the public health IP section and the strategic direction, which are found in the budget estimate section part A and also the strategic direction part B. There's nothing to report on with regards to capital expenditure for public health, because at this time there are no plans for capital expenditure. There are a few notable changes in this year's budget, most significantly a £1.3 million increase in staffing, which also includes IT costs. This is because of an increase in the number of staff. We've actually increased the size of the team from around 63 posts to 87. And the reasons for this are in line with our new strategy, which will be coming out in 2021, with a focus on COVID recovery. Clearly, there will be new challenges for all of us as we emerge from COVID. Also, looking at the additional challenges that are going to be brought upon us from COVID, including health inequalities, extra challenges around our BAME communities, mental health and suicide prevention, and also wider determinants, involvement in planning, place and housing, and so on. Equally, we've also brought in a new health protection team, which we need to do because of the reorganisation around Public Health England, and also an increase in our behaviour change team, who have been working on COVID relentlessly over the last 12 months. Also things like mental health and safety, vaccine hesitancy. We've been working with our behaviour change team to address vaccine hesitancy, and also a number of different non-COVID work strands across the organisation. Also, there's been a huge increase in demand for our data and analytics. Our team have increased exponentially around that because of the demand around COVID data and other data. So massive increase in our staffing numbers, mainly driven by the fact that there's a lot more work that needs to be done, and also to build some resilience into the team going forward. And also our peer review in 2018-19 encouraged us as an organisation to take a leading role across the system. In order to do this, we need people. Public Health are keen to take this on, and this will be built into our strategy also as a leader within health and healthcare. But we need the people to do that. So large increase in our staffing numbers. Was also an increase in our children's health numbers. Our children's health increased by around £1 million, and this was to cover off pay increases for NHS workers in our school nurses and health visitors commission services. We actually received additional funding for this from central government last year, so this hasn't impacted any of our other budgets in any way. There was also a slight increase in our adult provision of just over £120,000, and this is Public Health's increased contribution to a weight management initiative partnership arrangement that we have with both of the CCGs. In 2021, Public Health have actually seen an underspend due to the impact of COVID and the reduced footfall in many of our services, but this underspend will be added onto our reserves to tackle anticipated future demands from COVID and rolled into future years. And just final point really to say is that, at this stage our future grant funding from central government is uncertain, but we think at least for 2021-22 the estimate that we received just before Christmas indicates that it will be in line with what we had in last year's funding. So so fingers crossed that will all come to fruition and we're in a good place. So I think that's my summary. If you have any questions.
No, that's lovely, Jo. Yes, we do have some members already that would like to ask some questions. So I think the first person to put their hand up was Ron. Ron?
Thank you. Hi, Joanne. Yeah, I'm looking at pages 191 and 192 of the integrated proposal pack, and particularly key priorities under the strategic directions page 191. And it mentions one of the key priorities is early years and school-aged children, mental and physical health. if we turn over to 192 and we look at key revenue saving proposals, it actually says children, young people, health visiting and school nursing contract. If that is a target for savings, how does that match with one of the key priorities being children's health in schools?
Yeah, I'm sure Jim will back me up with this one, but we're not actually looking to take any money out of that system. I think we saved a huge amount of money when we renegotiated the school nurses and health visitors contract when it was put in place, I think a couple of years ago. It still has a number of years to run, yeah, we drove a lot of savings out of that contract overall, but we're not looking at taking any further monies out of that area at this point in time. Did you want to add to
we're either going to maintain the existing service or increase it? Yeah.
So we've redesigned. Thank you, Chair. So as Joe Doggett says, we've redesigned the service because, as you know, the government decided to take some money out of the public health grant. So we redesigned the service to introduce a greater skill mix and get more people. And actually, as you now know, it's an integrated service with the family service and they're doing more. Whether we can increase the funding of that service, I don't know, but they are, our family service are a really good provider who are keen to do more, and we've worked closely with them. And in fact, we had a national visit from a number of national government departments to look at what we're doing. So if there is a way we can get more out of that, then we will seek to do it with them.
Thanks, Jim. Between you, I have a follow-on question. On Agenda Pack, page 18, which is, I think, the 4th page of the item 3, 7th page of item 3, paragraph 2.30, it mentions the savings that are necessary over the whole council. And at the bottom, it's identified a gap of 27 million over the next 4 years. Is any of that likely to come out of public health? Are public health fairly immune from contributing to that 27 million, or will we be expected to contribute?
Jim, would you want to take that?
There's probably two bits to the answer to that. The first is that as long as the public health grant continues and the ring-fence direction on funding public health services continues, then not immune, but it's ring-fenced for those purposes. Yeah. But there are other things that the council does that contribute very strongly to public health outcomes. So, for example, My Baby's Brain, which is a programme for building a kind of strong emotional bonds between mother and child and father and child, actually have important neurological benefits for long-term development. And of course, if those may be at risk because of the financial situation described in that graph, and they had important public health outcomes, every year when public health does its prioritisation process, and members will remember the kind of 16 criteria report that that kind of mammoth thing that landed in previous panels, and we think they're really important. Then we may move to kind of invest in those specifically on public health grounds. And I'm trying to find. Sorry, my head's full of vaccine hesitancy webinars for primary care, so I can't remember the example I was about to give of where we moved in to do something.
Don't worry, that's great, Jim. And thank you, Ron. Thank you for clearing up the children and young people eagle eye bit you caught there. So that's very helpful. Thank you. May we move to Fiona next, please?
Thank you, Chairman. And the question that I had about ring-fenced government grants, that was answered in your presentation, Joanne, so thank you very much.
Thank you, Fiona. And then we have Nigel, please.
Thanks, Annie. Yeah, I'm going to go back a little bit to what Ron was asking, but in slightly different direction. If we look at the where are we? Page 195 of the budget pack. What are the key risks in delivering projects for this portfolio? I think there are two there I've highlighted, number 1 and number 4. Number 1 is reduced investment in prevention activity. And given that prevention is the key thing that Jim has been pushing for as long as I've been on this council, I do not understand why we are even thinking about reducing investment in that area. And the second is the reduction in funding from central government. Now, I mean, I say this every year at this point. I see no logic behind the council's position that public health can only be funded from the public health grant. Why are we not, as a council, prepared to put our own money or our residents' money into public health projects, given the well-established efficacy of investment in this area? I think Tim last year quoted £1 spent here is £12 worth £12 overall. And I've seen bigger numbers than that actually recently, particularly in the context of the pandemic we are going through. The importance of spending in this area is surely as high as it's ever been. And I'm sure the public would want to see us putting more resources into this area.
Thanks, Nigel. A point very well made. Jim or Joe, would you like to address Nigel on that point?
From the point of view of the report, I think it's fair to say that we're not looking to cut any of public health's preventive activity at this stage. We were just highlighting the risk of cutting preventive activity should the need arise and should our funding fall short. Yeah, I mean, I'll let Jim talk about the funding from central government. Perhaps it's very unhelpful. You know, we have very little notice of what our funding is going to be. It's quite hard to run any kind of a business without realising what our funding is going to be until the 11th hour, as ever. But I'm sure Jim will talk further on that point.
Thank you.
Yeah, thank you, Joe. I mean, it's not unusual to be told what our public health finance allocation is a week before the start of the financial year, which kind of makes financial planning an interesting exercise. I think you may remember that this panel was one of the panels which considered the Hertfordshire prevention strategy. And I think as we come out of COVID, I think perhaps Nigel is inviting us to go back to that prevention strategy and look at how we become a preventive council, because we won't be able to, no public sector organisation will be able to afford not to do prevention, which is I think the way to frame it. The issue is how we demonstrate that prevention can improve outcomes and stop people needing more expensive services down the line. And I think that's a challenge that we need to, every agency needs to go back to, and we need to spend some time thinking about, so we can actually really go for it. I think prevention probably needs to be one of our top priorities.
Thank you, Jim. And I'm sure that post-COVID, that's going to be very high on the agenda. I think climbing out of this in terms of what we're going to be asked to actually deliver. And I'm sure you're speaking to all your peers. Yes, sorry, Nigel.
Sorry, if I could just come back on one thing. I mean, I totally appreciate the position that Jim and Joanne are in here, and it's a very difficult one from a planning point of view. I would just point out that although there are no specific cuts, if we look at the analysis of revenue budget by objective areas, everything is flat from next year. So that is actually a real terms cut. I understand why it's like that. It's because the assumption is that the public health grant is flat. And we can't make any other assumption, which is, to me, the illogicality of determining what I think is a very important budget in this way. But thank you.
Thank you. No, we totally understand what you're saying. I've just got one more member, and that's Margaret, please.
Thank you, Chair. Sorry, I'm just having a little trouble with my. Thank you. Thank you, Joanne, as well, for talking us through the IP budget paper. This is more of a strategic question, probably to Jim, actually, but I am quite alarmed, really, about NHS reforms in the middle of COVID and the closure of Public Health England. And he did mention that because of the closure of Public Health England and the creation of the Institute of Public Health, that we are going to need more staffing within Hertfordshire to cover responsibilities that used to be covered by Public Health England. I just wondered, I'm very sorry, I wasn't on the working group for the IP budget, and unfortunately I've had COVID as well, but I just wonder whether Jim could talk me through, or talk us through, a little bit about the strategic direction of the knock-on effects of the closure of Public Health England, because and he mentioned it as part of staffing costs, but I just would like to know a little bit more strategically as to what will be needed, and also the difference between the Institute of Public Health and Public Health England. I'm not sure I really agree with it as a reform, but if he could just explain that, I'd be very grateful, because I think at this stage we need to know what strategically this will really mean for us.
Thank you, Margaret. Jim?
So Chair, if I start rambling, you may just want to kind of, shut me up or give me a kick.
Yes.
Margaret, I'm really sorry you've had COVID. I hope you're on the mend. It looks like you're on the mend, so I mean, thank God.
I'm out of isolation.
Thank God. That's good to hear. So I think the strategic direction for us, and I'll cover this in a bit more detail maybe in my update, is first of all, we have to get COVID absolutely down to the point where it is as low as possible. And I mean, I think there is a national choice to be made about whether we're going for zero COVID or low COVID, and okay, even if very few countries have got zero, a number of them have got as low as possible, and I think that's where we need to go. So there's something about creating the epidemiological conditions to exit lockdown and reopen the economy safely and constructively. Then there is the whole issue of recovery and how we deal with the massive financial and mental health and other health consequences of this that will be a 5-year haul. So we will rewrite the public health strategy, which is already started. We will contribute to growth, to recovery and growth as much as we can out of that. So if you like, that's the sort of strategic landscape where we're going. Now, no health service can cope with the amount of illness that will be created even from long COVID. So we are going to have to, as a society, face prevention as a strategic challenge within this. Now, within that, government has decided to abolish Public Health England and create the National Institute for Health Protection. And this morning, I believe the white paper on the NHS was published. So these two things are going along kind of side by side. Now, government has decided to delay the creation of the National Institute of Health Protection for 6 months, which is sensible given where we are in the middle of the pandemic, that the very people who should be responding to COVID shouldn't be engaging through this. I think there is also a kind of discourse about taking the German model from the Robert Koch Institute. And members will know that I am a bit of an anorak and know the German system reasonably well. And the German system, first of all, does health improvement as well as health protection, the Robert Koch Institute. The Robert Koch Institute is much smaller than Public Health England, but only so because actually German municipal public health departments do the vast amount of public health in Germany, and they do health protection, and they are very well funded. And as you know, I've been taking Germany before they too had the massive peak that we've all gone through as a classic example of how to do municipal public health and certainly health protection. They did amazingly on contact tracing and testing. So there's also the fact that in Germany there is a network of these federal non-university institutes like the Max Planck Institute and a variety of others that are all organs of federal government or quasi-governmental that do things like Public Health England. So if you look at, and I think, and the Association of Directors of Public Health has said, NIHP, if you're going to do the German system, you need to do the German system. You need not to do a bit of the German system. And you need to do, and actually, some of you will remember the Health Protection Agency from 2008. And when that became PHE in 2012, Public Health, it was brought together specifically so that health protection, health improvement and data and all the other stuff would be done together. And we have benefited enormously from that. And that's how we do public health locally. You can't do health protection without doing health promotion at the same time. So I think that's probably a bit of a whistle-stop tour of this is still a work in progress, but the lens for what we need from health system reform for the future must treat social care as absolutely integral to the health of our population, must treat public health as integral to the health of our population, and must put local government at the very centre of that, even if only because of what local governments, districts and counties have achieved in the last year. I'll stop there, Chair. I hope I've answered your question, otherwise I really will go on all day.
Yeah. Could I just make it slightly more focused, just to say how many of the staff that you are planning to, that you need, the increase in staff, are really due to the closure of Public Health England, and you would see as roles within Hertfordshire that used to be done by Public Health England?
To be honest, it's too early to say. The vast majority of staff we have recruited in the last year have been recruited because of the volume of work created by COVID. Mm-hmm. And the fact that no health system would be anything other than overwhelmed by what we've just been through.
Yeah.
And, you know, I mean, Public Health England could have been 4 times the size it is currently and still be overworked. And so could we. So going forward, I don't have an answer yet, but we are looking. I think we will need a health protection team going forward because COVID is going to be around for at least the next 2 years, I think.
Yeah. I actually was thinking more of Public Health Intelligence that Public Health England used to do. I'm very concerned about where that's gone in the Public Health, the Institute of Health Protection, and how that's still going to continue, because Public Health England had developed, you know, it wasn't complete, but it was a very good national model that they had done very well between 2013 and now.
So as you know, our Public Health Intelligence team are actually quite large. They're all working long hours. They're not even large enough to do everything that's asked of them. But they develop significant numbers of dashboards, and actually they are working with Public Health England and the University of Cambridge on some of the national modelling. So rest assured.
Can I just say that we've got quite a few other members, if that's okay. But I just want to say, Margaret, I'm really pleased you asked that question, because I think the panel should be, obviously, the important thing is to look at the strategic landscape going forwards, and COVID has changed everything. So I'm sure Jim was going to give us some of that later on, and we've got a whole item on COVID recovery later on. So if there's anything more specific to the IP, should we just get that out of the way? Because I can't wait to get on to Jim's bit later on, if that's all right. Yeah. Okay. So I've got 2 more. Lynn, please. Lynn.
Thank you, Chair. It's sort of part of this. It probably comes up later as well, but I'll bring it up here if it's okay. I think public health has really come to the fore during the pandemic. It's something that we've all been aware of for many years, but probably not really seen outside until recently. And about a couple of years ago, we did ask if we could get public health reports on each report that came out of every department, just as we do for equalities. And unfortunately, that hasn't happened yet. But I think if we could get that going, it's something we've been pushing for ages. it would really help the team to show and push for money in the future, because so often they ask for evidence, and I think unless we start getting every team within the council to consider the impact on public health, it makes it harder for us to apply for more money, or as Nigel was saying, to put even some of our money into budgets. So I'm a great one for looking up. So can I just ask, is that still in the pipeline as something that we intend to do? Thank you.
Thank you, Lynn. Jim, how's that progressing?
So there's you know that this panel has had fairly dear to its heart and has been pushed by Tim and by you to kind of adopt this health and policies approach, and all members have done that. So it is on the list. It's just been held over because of COVID. But point well made and point well taken.
Yes. Thank you very much, Lynn. I think that is very important, and you're right. Public health is going to have a much bigger magnification now. I know a lot of people on this panel, beyond, in terms of long COVID, have been affected by chronic fatigue after other viruses. So actually, the work that we're going to see coming on is going to benefit a much larger proportion of society than just COVID, which is great news. So I don't think I have any more members that wish to speak. So are we happy? Do we have a vote now that we're happy well, we've had these comments. I don't think there's any specific areas, new areas that the panel feel that needs to be sent to Cabinet for Friday. Am I right in that? And if I'm right, officers, do I need to have that agreed in the chat? Well, would you like to do that? Would you like to say that you're in agreement on the chat? That would be great. Thank you. Splendid. That seems to be unanimous there. So thank you very much. A couple more coming in. There we are. Thank you. So if we can go on to item 4, please, on Agenda Pack 21. And this is Saving Babies' Lives. And it's an update on the pilot incentive scheme. And I hope we've got Emily Clark, who's the strategic lead on adult health improvements here. Do we have Emily? Lovely, Emily. Thank you. Good morning, Chair. And you'd like to introduce your report. Thank you.
Yes, please. Thank you.
I just clarify whether I've got an interest to declare, because I'm a practicing community pharmacist, and although I normally work in beds and bucks, until the end of February, I'm rostered in Croxley Green.
Lovely. Officers, do we know that Fiona needs to give?
Yes, that's fine, Annie. I'll note that.
Okay, thank you. That's been noted. Thank you, Fiona. Continue, Emily. Thank you.
Lovely. Thank you, Chair. Yeah, thank you very much for letting me bring this paper to you today. So this is an interim report on the Saving Babies' Lives, a pilot incentive scheme that was launched last January 2020. Launched within rather strange circumstances over the last 12 months, but hopefully the report has provided you some insight as to the progress of the pilot scheme. If it's okay with you, Chair, then I've pulled out a few of the 3 main factors that I'd just like to summarise to the panel and pop in a PowerPoint presentation, if you don't mind me sharing. It's just a few slides just to hopefully make it a little bit more visible for people.
Yeah, please do.
Thank you. So hopefully you will be able to see my screen. Can you see it, Chair?
Not yet, no.
That's frustrating, bear with me. Oh.
So while you're doing that, I just have to apologise to members. I'm sorry, I was a bit quick out of the blocks. The last item, item 3, there was a majority but there were some abstentions. So I correct myself saying that it was unanimous. I'm sorry about that. Couldn't see it all. Oh, good. We've got it now, Emily.
Excellent. Thank you. So this is just me and the update. The overview is very clear within the report as to what we're presenting on today. So it's purely looking at, it was launched last year. We're looking at targeting 300 of our most vulnerable women who smoke throughout their pregnancy, because we know that there is significant risk to them and their unborn child. And a target of 180 people, which would then quit at 4 weeks post their quit date. The eligibility criteria for the implementation was based largely on the Tappan and Ball trial, so that we could compare the data as part of the evaluation. And the women were offered intensive support, regular carbon monoxide breath testing, and then shopping vouchers at 4 key points of a total value of £300. So the report itself is looking at a feedback of three of the project objectives. Whether it increased the number of women that accepted a referral into Hertfordshire Health Improvement Service, who would provide the support. Did the pilot show that it increased the number of pregnant women who smoked beyond, stopped smoking in the short term? Short term we define as 4 weeks post-quit date, and for the duration of their pregnancy and beyond. So we would look at 4 weeks after their quit date, 12 weeks after their quit date and beyond, which is about 34 to 38 weeks of their gestation. And then improve longer term outcomes for baby, mother and baby. So that might be post-birth outcomes. So as the report has shown, we have a total of 522 women referred, and this is in the time period from 1st of January last year to the 31st of December. 282 women accepted support from the Health Improvement Service, which was 54% of those referred, and that is an increase from the previous year. And what I've done is just broken down the difference within the eligible cohort and those who are ineligible for the incentive scheme, because I think that's where it shows the real changes and outcomes for the scheme. So those that were eligible, you can see that the acceptance of support was actually at 71%, whereas those that were ineligible for the financial incentives, there was a much lower acceptance of the service, which is at 32%. So for the next objective, to see whether they actually stopped smoking in the short term, so for 4 weeks post quit date, so the women that come into the service would speak to an advisor, set a quit date, have some regular support. Of the 107 people, there were a total of 107 women who were smoke free at this point, and that is an increase from last year, which was 58. So you can see there's a significant increase in those that remain smoke free. And the quit rate has increased to 60%, and that's actually the same as the Tappan and Ball trial. Again, I've split it into the eligible cohort and the ineligible. The eligible cohort had a quit rate of 55% and the ineligible cohort 31%. So you can see quite a different rate there on those that were eligible for those financial incentives and those that weren't. And then for looking at data that is 12 weeks smoke free, a total of 67 women remain smoke free. Of those that were eligible for the financial incentives, that was equated to 60 women, and the ineligible was 7. So quit rates or maintaining their abstinence, you can see, was significantly higher with those that were eligible. And then the improved longer term outcomes for mother and baby. This sample size is very small due to it being an interim report. So I haven't shared that data because it's actually a really small sample size. So I don't think it's would have incredibly large confidence levels, so I haven't shared it, but it will be shared in the full report later in 2021. So you have to bear with us for some of the longer term outcomes, and then we can compare those to the Tappan and Ball trial. And the next steps that are included in the report is to continue the trial, the pilot, until we have achieved the 180 quits that we've set out and we have the budget to achieve. We're currently at 92. It would be interesting to review the eligibility criteria, because obviously there are some significant differences and the success rates are much higher with those that are eligible. And we would like to incorporate some case studies within the full evaluation report, which is again available later this year. And if I can then stop sharing my screen.
That's lovely, Emily. Thank you. So members, well, I'll take Anthony Rowlands first of all, because I think you've got to go, Anthony.
Oh, thank you, Annie, and thank you, Emily, for the presentation. I just wonder to what extent all the challenges we know and the difficulties in achieving face-to-face contact have actually been an impediment to you and your colleagues in trying to carry out this work over the last 11 months.
Yeah. Absolutely. Of course, it has had an impact. I think what is beneficial is the majority of our referrals come from maternity services. They have continued to be offering their consultations face to face. So be it that it's only perhaps with the pregnant women and maybe not partners or family members, they possibly aren't as part of those consultations. They have continued face to face. So they've used the appropriate PPE and maintained those initial booking appointments face to face for maternity services. What they have been unable to do, and this applies to the support for those women after they've referred as well, is we haven't been able to use carbon monoxide monitoring as one of our motivational tools that we would typically use for women as a recommendation to reduce any type of as part of infection control. So we haven't been able to do that. But the booking appointments have continued.
That's really good to know. Thank you very much. Fiona.
Thank you, Chairman. I've got a couple of questions. Let's get my ModGov there. I think item 4.1.4 on page 22, that the mothers have to sign to say that they won't be using the vouchers for items such as tobacco and alcohol. And what safeguards are in place to make sure that unscrupulous retailers do not take them for tobacco and alcohol? That's the first question. The second one's on the next page, page 23, item 4.2.1. That's last year, 54% of mothers referred that he did accept the service. So the 54% accepted it. So what work are we doing with the other 46%, the 46% who didn't?
Yeah. Very valid points. Thank you very much. In terms of the vouchers that we chose to use Love to Shop vouchers. We went through an exercise to see whether there were some shopping vouchers that could not be used, could physically not be used for the purchasing of anything to do with tobacco or alcohol. Unfortunately, those vouchers don't exist, so we had to put in a caveat in terms of an agreement with the women that came into the service that they had to sign to declare that they wouldn't use them for those gains. We're not able to go directly to the retailers to say, please don't do it. It is an element of trust that we are working alongside these women, but that does come as part of the general conversation we have with them, that they are engaged with the service to have better outcomes for themselves and their babies. And we do explain the overall view and the wider determinants of their health and have the wider impacts. So as much as we're not able to go to the individual retailers, we do put that caveat in place to say that it is an element of trust. And within the Tapin and Ball trial, that was identified as a risk within the trial. So we're basically replicating the trial as much as possible, but they didn't have any outcomes there that indicated that was being abused in any way. And the second point, in terms of the acceptance rates, you're absolutely right. It's gone up this year from 51% to 54%, which is excellent. The wider work that we do with maternity services, the conversations that the midwives are having, we're doing a lot of training, which is still continuing within this landscape, about how to raise the element of concern so that once they are referred, there's a friendly face or a friendly voice on the end of the phone to try and encourage them to accept the service and come in, even if they just want to have a conversation with somebody because they're not quite sure what we can provide or how we can help. Then they're the types of conversations that we are trying to encourage to absolutely increase that acceptance rate.
Thank you.
Thank you, Fiona. On Emily, on Fiona's question about those that haven't accepted it, do you see how many of those is it their first pregnancy, and are they likely to be encouraged with subsequent pregnancies if they fail this time to have another go?
I don't have that data as to whether it's their first or second pregnancy. We don't routinely record that in a format that would be easy to extrapolate. However, at every point of contact that the midwife has with the pregnant women, the question is asked as to their smoking status and would they like a referral, and they can be referred at any point during their pregnancy, which is great. We will welcome a referral at any time. And we also feed back to the midwives. So if they've made a referral into us, we will feed back to them to give the outcome of the referral and the outcome of their progress throughout their quit. And that's to help all of that sort of relationship building, so they can feed back to the lady to say, that's fantastic, well done, please carry on, those types of conversations.
Okay, I've got a hot switchboard of members here. I've got 5 in a row. So Nigel first, please.
Thank you. Yeah, just you mentioned eligibility, Emily, and possibility of relaxing those criteria. What are the criteria that are used currently? I was trying to go through the previous papers on this and couldn't find anything.
Okay. The criteria is essentially that they have they have to live in Hertfordshire or have a Hertfordshire GP. The main criteria for eligibility, which seems to be why people fall into an eligible or ineligible cohort, is at the point of referral. So whether they are referred before 24 weeks pregnant.
Oh, okay.
So that seems to be the criteria when you look at the data as to why people. So if they're referred later in their pregnancy, then they would not, if it's beyond 24 weeks, then they're not eligible. So we're encouraging the referrals to be as early as possible, because it has the better health outcomes.
Yeah, okay.
So that is the main criteria that seems to be whether they're ineligible or not.
Thank you very much.
You're welcome, Nigel.
Good question, thank you. Susie, please.
Hi, thanks so much. I just wanted to say thank you for a very inspiring set of figures, really, Emily. It looks great, and particularly because you didn't this time have the carbon monoxide monitor, the results seemingly are actually even greater than we see on the paper work at the moment, aren't they? Because with the carbon monoxide stimulus and enthusiasm for them, they may, you may have even better results. The thing I was going to ask was the offer of the financial incentive of £300 seemingly seems quite a lot, which is really something that will inspire people, I hope, to continue, as obviously does happen. I'm assuming that when the report finally comes out, there will be some aspect of monetarising the fact that although the investment, if you like, was £300, that the health benefits and the savings are greater than that. And it would be good to see that, excuse me, in the report.
Certainly, Sue, we can include some of that as much as possible within the final report, and I'll absolutely make some comments that we do so.
Smashing. I think that's important. Well, I'm sure it is for take up and continuing on from the pilot. This actually saves us money, so let's please continue. Lovely. Thanks very much indeed.
Really good point, Susie. The evaluation has to be there, doesn't it? And
oh, yes. Well, the monetarisation. Yes.
And financially and money. Margaret, please.
Thank you, Chair. I was just having analysed some trials. I hadn't actually heard of the tap-in and ball trial, but I was thinking that sustainability-wise, in helping women to stay off smoking, besides giving them a £300 voucher, have you thought of calculating how much money they are saving by not spending it on cigarettes? And actually, a bit like that programme on telly where they try to help families spend less money on food by eating more healthily and cheaper. There are incentives to try to make this sustainable and to help the women themselves see the benefit. Actually building on what Susie said, actually feeding back to them what are the health benefits, perhaps by taking some other measures as well of FEV and lung function, and helping them to see how much more maybe they can do exercise. Just over, you're actually really seeing them for a very, very short time compared with the whole of their life, but actually how this could be a life-changing exercise in a more holistic way, but particularly calculating how much they're saving by not spending it on cigarettes.
Yeah. Thank you. Can I just say, Margaret, I love that programme, Eat More for Less, brilliant. And Emily, really, it's a really good point here, how also it's going to be linked up to healthy hubs, because of course, if that's going to signpost in two directions, and Margaret's absolutely right, this won't be people's only issue. So how is that planned, please? Thank you.
Yeah, absolutely. All of those things are discussed with the individual, but I have to say that they'd probably discuss more so if that is their motivation to want to stop. So their individual motivation and the reasons for them presenting and accepting the service is one of the things that we talk about more than anything else, so that we can focus and have a really individual response and coordinated support mechanism for them. So finance is certainly a driver for this incentive scheme, but it might not be their overall driver. Their driver might be because they're asthmatic, or it might be there's multiple implications. So we would want to focus more so on that personal motivation, but we would include, yes, whether they want to engage in weight management service, exercise referral, if they're borderline for diabetes. There's all sorts of things, other things, and that's where the wider work of the Health Improvement Service would come on board to support and work alongside the Healthy Hubs. Absolutely.
Could I just, one other thing, are you going to show the outcomes of their pregnancy? Because I'm actually publishing a paper on the causes of preterm birth, and smoking actually and abortion are two major risk factors for premature birth. So it'd be very interesting just to follow through these women to see what their pregnancy outcomes were as well.
We don't have that as an overriding objective, but we can work with maternity services to see whether that data is available and then share it with you.
Thank you, Emily. Thank you very much, Margaret. Yeah, and maybe move to Ron, please.
Thank you very much, Annie. Yeah, I note that out of the 522 referred, only 292 were actually put onto the programme, and I just wondered, do we do anything for the 230 that were rejected? Did we refer them somewhere else? Do we actually look after them, or were there circumstances which could be dealt with by another part of the service?
Yeah, we certainly do follow them up as much as we can, Ron. We actually we inundate them with phone calls and letters, and we send them flyers and information. We feed back to the maternity teams to say, thank you for referring this person, but unfortunately, we either can't get in contact with them, the phone number's wrong, there's all sorts of issues, or we just can't get them engaged in the service. Is it a wider system approach because their partner smokes? Because we know that is in about 82% of cases that the partner will smoke. Can they come with them to a session? There's all sorts of things that we would try and do. But as mentioned earlier in an earlier question, that's absolutely something that we are focusing on to try and increase that number further.
That leads me on to my second question. But from your answer, therefore, I thought possibly that the fact that we didn't take those 230 was that they didn't necessarily qualify for the pilot. What you're saying, in effect, from your answer is that we've been trying to get them on the programme, but unfortunately, for whatever reason, and there's a multiplicity of reasons, we haven't been able to. So, which is a totally different system. So we've got the ability to put them on the programmes. It's just for one reason or another, which leads me to my second question. You mentioned that the take-up rate is up to 56%. Is that overall, or as I suspect, the cohorts which we are desperate to reach, the cohorts that have the multiplicity of conditions which actually endanger the births, are the ones we want to get to, and therefore they're the ones that are proving the most difficult. So that 56% possibly represents a higher level of take up from those that possibly need our services on the margin, and a lower take up from those that really need our services. Would I be right in that assumption?
I think the multifaceted reasons as to why someone might be more vulnerable, and that this pilot incentive was trying to reach those more vulnerable groups, we would only have that information if we if we can obtain that from maternity services at the point of referral. So at this point in time, I don't think I can give you a definitive answer to say whether they are or are not our most vulnerable, or whether they have complex needs, but that is certainly something that we could try and explore and incorporate into the wider evaluation.
Can I suggest then, I think part of for the usefulness of this service and to be able to target to the right cohort, I think we do need to have a better sharing of data from the maternity service, because if we haven't got some idea of background or some idea of the lifestyle of the mother and the parents that are being referred to us, we can't then establish whether or not we're getting to the right people. So I think an extra effort to try and persuade, and once again we're back to the NHS sharing data with us, which it seems to be a perennial issue. I think that is part of the key in actually seeing how successful this pilot is at actually reaching what the targets we want to.
Yeah, thank you, Ron. It's a really interesting group of ladies to acquire all this information from. I totally agree.
I can't even say you're sexist and say you've missed out men in this case.
I'm okay here. I can do this one in 2021. We don't know what's happened in the future, but there we are. William, please.
Thank you. A few little comments. The question to start with, how many fails have we had on a CO2 test? Because presumably you've been doing CO testing at some point during this last year. What's the proportion of failures on that? One of the reasons I'm asking is that in the schedule of payments, one would imagine that since you have not been doing CO testing for most of the year, I'm worried as to how confident we can be that the majority of missed tests would in fact have been all right. And then the final comment was to follow up the suggestion of looking at a woman who is about to get pregnant and currently makes the decision that I'm not going to smoke during my pregnancy. I'm going to stop. Now that I know I'm pregnant, I'm stopping, or possibly even beforehand. Are they possibly going to be deterred from stopping just before getting pregnant or shortly afterwards, so that they can then come to you and say, I'm stopping smoking. It's now 8 weeks into my pregnancy, so that I can earn some money from you? Is that possible?
Great question.
Very good questions. Thank you for putting me on the spot there so brilliantly. In terms of the failures of the carbon monoxide tests, yes, we were able to use them from the months of January to, I think it was something like the 13th of March before we had to stop it. So we do have 2.5 months of information there to say those that presented as part of our face-to-face support and whether they met the criteria of having a sustained carbon monoxide measurement under the number of 7, which is what we look for as our benchmark. Whether that has changed our confidence of having a self-reported smoke-free status, which is essentially what you're asking, that later on down the line, we're on a phone call, we're not seeing somebody face-to-face, so we have to take their judgment on it. Unfortunately, we don't have data from a different trial to compare that to, because they weren't going through a pandemic at the time, which made it impossible to use the carbon monoxide tests. We could have stopped the trial at that point, because that was one of our criteria to say that they had to report a low carbon monoxide status. However, for us, in terms of engaging with these women, if it meant we engaged with more women, irrespective of their vulnerability as such, if it meant one single pregnant woman and they had better outcomes, to us that was still a success for the trial. It's because if it actually meant that anybody in addition to what we normally have would come in and access the service, to us that was a benefit, because for any pregnant women to have a better outcome is to have smoke-free status for them and their child. So although I don't have that confidence data to be able to share with you, I can look at the data from last January, February time, and we would have access to that. And apologies for not sharing it within the report, but going back to whether we're confident, actually we build up a really good relationship with these women. We're talking to them on at least a weekly basis to make sure they've got support. Although the financial incentives have shown some very nice improvements in their quit outcomes, then I think it's all about that relationship building, and people will be honest with you on the phone. If they have smoked or they have lapsed, they will hopefully, because they're part of that service and they have that relationship, they would be quite keen to continue with that, and we would possibly, they wouldn't get that voucher, but they would come onto the service again. Oh, and in terms of, sorry, just going back to, would it deter someone that was wanting to stop smoking beforehand? They wouldn't know about the scheme, so I don't think it would have any outcomes to them, because the main part of the pilot incentive scheme would be discussed at their booking appointment. So at that point, they are already pregnant. So those that wish to stop will have already stopped, and they are not within our vulnerable group.
But once we've up past pilot stage, this sort of knowledge will spread. That's my concern.
Absolutely.
Thank you, William. And I think you're absolutely right. The ethos behind what you're saying is that this is just a stepping stone in getting smoke-free pregnancies. And going back to the point again, if they perhaps fail the first time or come to it late, their subsequent pregnancies, that they'll want to do this. So it's, I mean, I'd imagine in COVID, the pressure of wanting to smoke is being a lot higher. So, and I think what we're asking, we've got no other members to speak, but I think what we're asking here, or saying that once this is fully evaluated, and then the future panel will consider to formally integrate it into the scheme after next April. So that'll be a future panel. Some of us might be here, some of us might not, so we don't know. But can I ask members if they would like to vote to agree to that, please? Thank you. Lovely. I hope I won't make the same mistake. That looks like it's been noted and agreed by everyone. Thank you very much. Lovely. So now we go on to item 5 on agenda page 44, and this is the update on priorities for Hertfordshire Health Improvement Service and the delivery of stop smoking services 2019 and 20. And we have an officer. The officer who's going to actually give this report is Emily Clark, so Strategic Lead Adult Health Improvement. So Emily, change your jumper and yes, you can give us this report. Thank you.
Before we start, declaration of interest that I made for the last item, yes, I would think that will also apply for this one.
Lovely. Thank you for reminding us, and officers will actually take note of that. Thank you very much, Fiona. So Emily, are you sharing a screen or talking?
I probably will again, Chair, if that's okay.
Yes,
I believe this item will be a shorter report for you, but I'm afraid it is with myself again.
Okay.
So
we're delighted to have you.
Thank you. I just need to change my screen.
Well, as you're speaking, this is the interim report for 1920. That's right, and the full report will be available later this year to cover 20 and 21. So that's what we're doing there.
Sorry, Chair. I'm just sharing the wrong.
Are they? You've managed it. Well done.
Is that the right one?
We need it a bit bigger, I think.
Right.
Put the slideshow.
Is that okay, Chair?
No. Can you get the option with the slideshow? Then it will bring it up much bigger. I don't think members read that.
Well, I think it's the last item as well, isn't it?
Is it shared the wrong one? Bear with me.
Someone's got good eyesight, Nigel.
Right, my apologies. I'm trying not to share everything on my desktop with you because I'm sure you're not interested in all of it. Right.
Oh, we are.
Okay.
That's the one.
Is that the one? Right, perfect. Thank you. So as the report says, what we standardly do, and the reason that I brought this to you today is that I would typically on an annual basis, we would do reports specifically for the delivery of stop smoking services. This year, because our priorities have probably changed slightly due to the pandemic over the last 12 months, what I have done is I have just done an update on the specific recommendations which are included in your report. And what I wanted to highlight to you on just a couple of slides this morning is about what the changes were made to the service delivery and the impact of COVID, because I thought that would be more interesting to the panel members just to see how actually we have adapted to delivery of services, particularly to this key vulnerable group, and how, because the impact and severity of COVID can be far more significant for smokers and those with long-term conditions. So the priorities are in your report. There's nothing really essentially to say other than it has remained business as usual, and all of the 13 priorities that were set for last year, we have attempted and made really good progress on the majority of them. There have been a couple of examples where we are limited in some of our performance, and I've put an example there, is that we haven't seen an increase in referrals from the NHS acute trusts. Unsurprisingly, things like pre-operative, people who aren't going to attend for their pre-operative, they're not having their elective surgery. So unfortunately, the ability for a frontline member of staff to have the conversation and to assess somebody's smoking status and refer them to us is limited, and we just haven't been able to have that. But it doesn't stop us from trying and engaging with all of those staff members, and those are all priorities that will continue into 2021. The main impact on COVID to the change of services, and I literally have 2 slides for you just to share some of this information. So when we went into the lockdown in March last year, the delivery of all stop smoking services across Hertfordshire, which typically are by our core team delivered face-to-face and by GP surgeries and community pharmacy delivered face-to-face, all of that delivery switched to phone support overnight for all of our stop smoking clinics. And also, if we've mentioned in the previous agenda item, we did have to stop obviously using the use of carbon monoxide monitoring for all of our services as a motivational tool, because we were delivering everything on the phone. There was a significant reduction in activity within our commission services and GP surgeries and community pharmacy as they were pulled into other activity. And the direct delivery of clinical, and HHIS is the health improvement service, by our core team, the clinical delivery actually increased by about 100%. So everybody was delivering clinics left, right and centre to try and help with the increased demand in referrals, which was fantastic. During the initial lockdown, smokers were prompted to change. A lot of people to the service, and our referral numbers increased by 45% between April 2020 and recently up into January compared to the previous year. So the total number of referrals that came into the service significantly went up. And it became a period where we were able to be slightly more innovative. I think it was mentioned in the a little while ago in this morning's meeting about public health being sort of the focus of people's attention, and sometimes they haven't heard of public health, or they may not have taken some actions to do with their own sort of investing in their own health. We took the opportunity to send out text messages to everybody that had previously come into the service, so anybody that had previously engaged, irrespective of the outcome. And we also worked with our CCG colleagues and the primary care networks to send out text messages to all registered smokers, which helped with our massive increase of referral numbers. We did some significant comms, and that is continuing. We've tended to do sort of monthly comms to everybody, all of our external stakeholders, including the Acute Trust, Drug and Alcohol Services, to tell them that we're still there, that actually we're delivering everything on the phone rather than face to face, but now's an ideal time to approach the service and to engage. We put flyers in shield packs, which were sent out to our vulnerable groups. We also did a COVID-specific flyer to use in prescription bags, which was sent out by community pharmacy colleagues. We did a radio advert. And we also managed to maintain a large amount of remote delivery of training. So when the teams were available within the acute trust, for example, or within family centres, the University of Hertfordshire for their midwifery programme, for example, we were able to deliver all of our training remotely, and everything had to be adapted to deliver via MS Teams. So they were some of the specific actions that we took over the last 12 months. And the next steps really that are included in the report are just to review what the impact of these significant changes to service delivery are, and what impact does that have on health inequalities, in particular access to services.
Wow, thank you, Emily. Just to give you a rest for a moment, and just because I think Jim's feeling missed out. Jim, can I just ask the question? Do you think that the message of the dangers of smoking in relation to COVID recovery has been lost a bit recently? It was full on at the beginning. Is that because evaluation showing it's not as serious as thought, or is it just that ministers aren't mentioning it anymore? And public health scientists and whatever. Thank you.
Thank you, Chair. I'm not feeling missed out. I've been enjoying listening to Emily, and makes a nice change for me banging on. I think the short answer is people have been so busy that they've forgotten the Quit for COVID message, and it is one set of issues alongside other issues like diabetes and other things. But our Quit, Emily will correct me if I'm wrong, but our Quit for COVID service is still running. They're still taking referrals and we're still pushing it. I think it's just dropped from the media spotlight at national level. But our local media colleagues have continued to push it for us, which is really helpful.
Okay, I mean, it's just helpful to give this sort of feedback, isn't it, from grassroots, if we're feeling this, and this panel's seen that these are measures that should be repeated and repeated. So lovely. So I've got Fiona first, please.
Thank you, Chairman. I'm running between Teams and ModGov, so hence the delay when I switch from one to the other. Anyway, I'm ready to go now, and I'd like to ask, what use is there of a PGD, a patient group direction in Hertfordshire, whereby specially trained pharmacists give out the prescription-only stop smoking aid Champix without a prescription after being referred by the Herts County Council Stop Smoking Service? This service operates in Bucks. Currently, as I said earlier, I'm being rostered in Croxley Green, but I've seen a lot of standard GP prescriptions for Champix. So using this patient group direction, that basically frees the GP to do something else.
Yeah, absolutely, Fiona. We actually do have a PGG for the use of varenicline within Hertfordshire. Which there is a training programme attached to the PGD, which is essentially done once, possibly twice a year, where any community pharmacy within Hertfordshire can sign up to deliver under that PGD, because you're quite right, it does free up some of the time for GP practices. So that does exist.
Thank you.
That's a brilliant question, and great you can do so much for us, Fiona. Margaret, please. Oh, Jim, did you want to come in on that point?
Sorry, Chair. Having said I was enjoying listening here, banging. I think if Emily and I take that offline and look at whether there's anything else we can or should do, then we'll do that. Sorry.
Okay, thank you for that. That's great. Margaret, please.
Thank you, Chair. And actually, just to add to that, I remember doing an analysis in Newham that showed that the pharmacists had a much more successful quit rate actually than the GPs. So actually that's a little bit of an incentive there to perhaps get that training for pharmacists advertised. I was going to just ask about methods, and you mentioned innovative methods of giving up with the Herts Health Improvement Service. Because I also remember doing an analysis in Hertfordshire when we had group stop smoking, groups of people who were well, they weren't self-supporting. They had a health improvement member of staff in the group to help discuss giving up smoking. And I just wondered whether in COVID that had ever happened, whether you've done group work on Zoom or anything like that. I realise IT could be prohibitive rather than a phone call, but the actual bit like Slimming World and Weight Watchers, that the group benefits of them all giving up together and encouraging each other to give up, especially if a spouse might still be a smoker, is an incentive for smokers giving up. And I just wondered if we'd explored that.
Good question. Thank you, Emily.
Yeah, absolutely. It's very timely that we are exploring that. Group sessions used to run routinely for the treatment of stop smoking. It is not something that we've done locally in Hertfordshire, other than within workplaces where we do still deliver some groups. We haven't done it as much, and certainly not over the last 12 months. Some of that may be due to the pressures on staff to be able to respond appropriately to the amount of referrals that have come through. But it is something that we discussed just last week about whether we need to explore when we come out of this, and if we are to return to face-to-face delivery, actually whether we need to have a wider offer of stop smoking support. So whether we may still maintain phone delivery, we would certainly encourage spouses and partners to come to that, whether we do some face-to-face, and actually, yes, whether we look at delivering of more groups. So it is certainly a consideration, and I think that it could be a good offer that we look at doing more of.
Lovely, thank you very much. You might see in chat that David Conrad has put a link in there about actually a study about smoking and COVID. So that's quite useful if you want to have a look at that. William.
Thank you. Before I ask my question, I ought to point out that I'm Hertfordshire's appointed governor to the Royal Free Trust, which operates in London and outside Hertfordshire, but has a lot of patients coming in from Hertfordshire. My question is about the priority, which states that we are trying to increase stop smoking referrals from all NHS providers. So my question is, does that include providers outside Hertfordshire who are serving Hertfordshire residents? And are you getting adequate cooperation from those external providers? Because last time I was at Chase Farm, there was adverts for the Enfield stop smoking service, which is the local borough, but they didn't include Hertfordshire. And a lot of patients go to Chase Farm from Hertfordshire.
Really good question. Thank you for raising it. Yes, we have links with all of our border hospitals. So we have either a stop smoking lead or a respiratory consultant lead or somebody in place in every one of our border hospitals to look at making sure that Hertfordshire residents come through into us. And we have sort of mutual agreements with a lot of the services that, for example, if we had someone from Bedfordshire come to us, that we would refer back to their local service. So we have a sort of quid pro quo relationship. Somewhere like Chase Farm, there's a lot of border hospitals that also use the national referral system, which actually means that if their details are recorded on their clinical system within the acute trust, it goes through a national system, which is then based on their patient household postcode. So it goes to their most appropriate service. So the adverts might be for one particular service, but if the clinician records them on their system, that data is driven. And we talked about data sharing. This is an example where it works really well. Barnet, Royal Free, they all do the same thing. They go into this national system, and then those referrals come to us directly.
Splendid. That's really good to know. Thank you. Thank you very much. So I don't have any more members wishing to ask questions or comment, but I would like to ask if you would vote to note the report, please, in the chat bar. Thank you, everyone. That's wonderful. And Emily, thank you very much. Quite a marathon session for you, but really informative. And we look forward to reports coming back later on in the year on the progress of these things. But well done and thank you for your work. It's wonderful. And members, how do you feel? Do you think it would be nice to have a break now? Or do you want? Yes, I think so, because you've got 2 more items. So it's a bit more of a natural break now. Am I getting a thumbs up from people?
Yeah.
Yes. Lovely. So we'll have a 15-minute break now. Yeah, always lots of yeses coming up. So a 15-minute break now. So we'll come back at 22:12. I got that right? Lovely. Okay. See you shortly. So lovely. We'd like to move on to item 6, please. And this is an item on COVID-19 and the health inequalities in the BAME communities. And this has involved 3 officers, Kazim, Claire and David, and they're all here on online for questions. But I think I'm going to hand over to Claire to start with, please.
Hello everyone, thank you very much for this. Yes, I'm down as a co-author, but I should say that Kazim Bibijan, my colleague, is the one who did all the hard graft and worked on this, and David supplied some of the data and they worked on that. So, but very happy to introduce the report. So as members will know, the issue of health inequalities has really come to the fore during the COVID pandemic. And one of the areas that we've been particularly concerned about has been the effect on our Black, Asian and minority ethnic communities, the health inequalities effect on them. And this report, for noting really, the contents of it is really looking at the high impact on those communities of health inequalities and focus on the impact that COVID has had on mortality rates as well. And Kazim can take us through the report.
Thank you very much, Claire. Thank you, Kazim.
Great, thanks, Claire. I've got some slides, if that's okay.
Yes, please. Be lovely if you load those.
Share that. Can everyone see that?
Yes, oh, perfect. That's nice and large there. Thank you.
Okay, great. Yeah, so as Claire said, so this presentation is really going to be, summarising the evidence so far that we have about the factors associated between ethnicity and infection with COVID and potentially poorer outcomes with COVID. So as we know, there's been a lot of coverage about the link between BAME populations and COVID. So this is sort of describing, what information do we have so far from the national literature and research, and also in Hertfordshire, what has the impact of the pandemic been on BAME communities in Hertfordshire. The first thing to really note is when we're talking about ethnicity, it's really a term that encompasses a lot of different factors such as race, genetics, country of birth, language, culture, and religion. So this diagram is really just showing the number of different factors that are all sort of intercepting and creating this higher risk of death from COVID-19 and higher risk from being infected with COVID-19. And they're all linked to different sort of components of ethnicity. So, housing, overcrowded housing, multi-generational housing, higher prevalence of pre-existing conditions, are all related to a higher risk of COVID-19 and a higher risk of mortality. So if we start off by looking at broadly the factors associated with COVID generally, and we know there are a number of factors that have been identified in the literature. The ones I've shown here are particularly strong in the literature so far. So we know age, pre-existing conditions, housing, occupation and deprivation are all quite strongly linked with COVID-19 infection and higher mortality. So first of all, starting off with age, we know that data from ONS has shown that compared to people under 40, the chances of dying from COVID-19 are 70 times higher for those over 80 and around 50 times higher for those aged 70 to 79. And you can see this demonstrated in ONS recent data going up to 22nd of January. So the next factor we know about pre-existing conditions. So this is obviously very linked to age. Those of older age are more likely to have pre-existing conditions affecting their risk of poorer outcomes. So we know from the data that deaths involving COVID-19, people have around 2.1 pre-existing conditions for those aged 0 to 69, and in older populations this is much higher. And this is a graph from a study from around 20,000 patients looking at pre-existing conditions of those who died. And we know that chronic cardiac disease, diabetes, and chronic pulmonary disease are, some of the factors associated with higher mortality. So what we can do with this data is look at this through the lens of ethnicity. So when it comes to pre-existing conditions, how do these match up to the prevalence rates in BAME communities? So we know that amongst those who have died in hospital, about 1 in 4 had a pre-existing condition of diabetes, 1 in 6 had dementia, and 1 in 6 had chronic pulmonary disease and chronic kidney disease. And if we look at the diabetes prevalence in BAME populations, we know from estimates that BAME populations have 3 to 5 times higher prevalence of diabetes compared to those of white ethnicity. And the other risk factor that's been identified is obesity. And we know from England data, around 3 in 4 adults of black ethnicity are overweight or obese, and around half of those of Asian ethnicity. So the next factor we know is about deprivation. So this graph is essentially showing the higher rates of deprivation are associated with higher age standardized mortality rates. So these are basically death rates that have been adjusted for the influence of age. And we can essentially see that all-cause mortality rates are nearly twice as high in most deprived areas of England compared to the least deprived. So again, if we look at this through the lens of ethnicity, we know that those from certain ethnic backgrounds are more likely to live in more deprived areas. So compared to the white British population, it's around 1 in 12 people of white British ethnicity living in the 10% most deprived areas of England. However, in 2011, in the ONS census, we know that 1 in 3 people of Bangladeshi ethnicity or Pakistani ethnicity live in the most deprived area, and you can see this depicted in the graph. So the next factor, the fourth factor, is housing that has been identified. And when we talk about housing, it's really talking about overcrowded housing and that link to making it harder to isolate and closer contact, making infection more likely within a household. And we're also talking about multi-generational housing. So this means people from multiple generations, from children all the way up to grandparents, living all under one roof. And this graph is essentially showing more overcrowded areas, such as Newham and Brent, are more likely to have a higher COVID-19 death rate. So again, if we look at this through the lens of ethnicity, we know that overcrowding is higher in BAME communities. So 1 in 4 Bangladeshi households and 1 in 4 Pakistani households are classed as overcrowded. And just to note that when we talk about overcrowding, this essentially means you have more people in your household than rooms, essentially. And the second factor is multi-generational households. So we know that around 1 in 3 Pakistani households and just over half of Bangladeshi households are multi-generational, compared to 1 in 50 of white ethnicity. The next factor we know about is occupation. This is a graph essentially showing a standardized physical proximity measure, which is sort of a proxy for risk of COVID infection based off the nature of your occupation. So you can see this plotted by death rates, and these are all occupations that ONS have identified as having a statistically higher death rate. So we can see security guards, care workers, taxi drivers, nursing assistants all have higher rates of death compared to other occupations. Again, if we look at this through, with the idea of ethnicity in mind, these are 17 occupations amongst men that ONS identified as having a higher rate of death. And through their research, they identified 11 of these 17 higher risk occupations have higher BAME populations. And key examples of this are security guards, which have a relatively high risk of higher mortality. Around 15% of security guards are from a black British ethnicity, and around 11% are Bangladeshi or Pakistani. Around 3% of the working age population is Bangladeshi or Pakistani ethnicity. Another key example of this is taxi drivers, where just over a third are Bangladeshi or Pakistani ethnicity. So to sort of sum up the overall risk by ethnicity that has been identified in the national literature, we can see from this data, looking at the rate of death compared to the white ethnic group, we can see that Black African males have some of the highest risk of dying compared to those of white ethnicity, and Bangladeshi men are 1.9 times more likely. And the key thing to note from this graph is really, you can see as they adjust for the factors. So if you adjust for age and you adjust for geography and you adjust for socioeconomic factors and health status, you still have a statistically significant higher COVID mortality rate. So moving on to the Hertfordshire context. So I'll go through this bit by bit. It's a lot of numbers, so I apologise for that. So essentially, the key thing here is to note what was the story of Hertfordshire in terms of health inequalities pre-pandemic, because it really matters to look at the starting point pre-pandemic to see how the pandemic panned out in terms of outcomes as a result of what the health status of residents in Hertfordshire were before the pandemic started. So you can see here underlined, these are the 3 districts in Hertfordshire that have the highest BAME percentage population, and obviously Watford is the highest there. So the key thing here, if we start off with life expectancy, so a key kind of indicator of inequalities is life expectancy, and you can see the ones highlighted here are the four districts with the lowest life expectancy in Hertfordshire. And secondly, if we move on to housing, so if we look at population density, and we can look at percentage of households with an occupancy rating as a sort of proxy for overcrowding, and we know that Watford, Welwyn, Hertsmere, Stevenage and Broxbourne have higher levels of overcrowding compared to the rest of Hertfordshire. And if we look at age, as I mentioned, age is a higher risk factor for COVID. And we know that Hertsmere, Three Rivers, North Hertfordshire all have a significantly higher older age populations. And then we can look at deprivation. So deprivation is highest in Hertfordshire, in Hertsmere, Stevenage and Broxbourne. And we can further look at the population of key workers. So this is obviously particularly important for occupational risk. And we know that Hertsmere, Three Rivers and Stevenage have the highest percentage of population of key workers in Hertfordshire. So the next thing, if you remember what these factors of inequalities that existed pre-pandemic, we can then look at what was the actual incidence over the last year by district. So we know that Broxbourne had the highest incidence rate with just over 6 in every 100 people infected over the last year, followed by Watford, which is around 5 in 100, and Hertsmere. And you can see the deaths per 10,000 population depicted here. And clearly Hertsmere has had the highest deaths per 10,000 population. So if we look at this by ethnicity, so if we start off on the left here, we can see that the incidence of the number of cases per 100 people by ethnic group, those of other ethnic group had the highest incidence. So this includes sort of Chinese population, Arab population, and obviously other ethnic groups that are not here. And the key takeaway from the table on the left is really that BAME communities in Hertfordshire make up quite a small proportion. Around 1 in 8 people in Hertfordshire are from a BAME background, but despite this have made up around 1 in 5 cases of COVID over the last year of the pandemic. So in other words, the incidence of disease is around 7 times higher in BAME communities in Hertfordshire compared to those of white ethnicity over 2020. So on the right here, you can see the link between deprivation and cases per 100,000 people in Hertfordshire. And the key takeaway here is more deprived areas have higher incidence, and on average it's around 1.4 times higher for those living in the most deprived areas of Hertfordshire compared to those living in the least deprived areas of Hertfordshire. So the next thing we can look at with the sort of limited data that we have by ethnicity specific to Hertfordshire, we can sort of plot the BAME population by incidence. So on the left here, you can see districts plotted by the percentage of BAME population that they have and the incidence over the last year. And it's sort of showing a general trend, a general positive trend where districts that have higher percentage of BAME populations have seen a higher incidence, and you can obviously see Watford is a clear indicator of this. And on the right here, we can plot deaths as well. So you can clearly see a positive trend towards districts that have a higher percentage of BAME population have a higher age-adjusted deaths per 100,000 population. So the next thing we can look at is overcrowding. As mentioned, that's a key risk factor when it comes to ease of isolation and chances of infection within your own household. And here you can see districts plotted by the percentage of households that are overcrowded. And again, you see a positive trend towards the more households that are overcrowded, the higher the incidence of COVID over the last year. And then we can then plot that again through the lens of ethnicity and see, you know, amongst those households that are overcrowded, what are the percentage BAME population? And again, you can see districts that have a higher percentage of BAME population are more likely to have overcrowded housing. So really, it's sort of a summary of the impact that COVID has had over the last year of the pandemic. And the kind of key points here are, it's clear that from the national literature that those from BAME backgrounds have been disproportionately affected by COVID. And some of the key contributory factors towards this have been the high prevalence of pre-existing conditions like diabetes, like obesity, multi-generational and overcrowded housing, occupational risk, and obviously the deprivation in poorer, deprivation is also linked to poorer outcomes. So it's really highlighting that COVID has really exposed and emphasizing inequalities that existed prior to the pandemic rather than created new ones. So really the headlines really from the sort of descriptive analysis that we've done is that specifically in Hertfordshire, BAME communities really make up a small proportion but have been disproportionately affected by the pandemic with 7 times higher incidence, and Watford really was a key example of a district that has experienced the highest incidence. And sort of moving forward from this and how this kind of influences other areas of work which are already happening, that I'm sure Claire will probably talk about, is really highlighting the sort of intersectional nature of factors influencing the higher incidence and the higher mortality rates of BAME communities in Hertfordshire, and it's important to consider for designing future interventions. So, great, thanks.
Oh. Kazin, thank you so much. I think at our briefing I said that was an astounding piece of work, and I think it's I think you've added even more to it since then. So it's really fabulous, and I think members might actually like your slides as well as our report.
I'm happy to share those.
Yeah, because it's really useful in lots of the work we do. Before I take some questions, can I just check that, Jim might want to come in here, but do we assume we're going to have, and now I suppose we've got to assume we might have future pandemics, and whether they're quite likely to have impact in the same types of underlying conditions. This work is wonderful, and as you say, Claire will probably tell us what are we going to do with the work. So it's giving us some evidence, and it's staggering to see the incidence is 7 times higher in the BAME community. But in terms of percentage mortality, when one has already got the virus, as our public health hats on, looking in terms of how we can address those reasons why the diabetes and the kidney and the pulmonary and the cardiac issues, and in terms of what we can do in our work to actually have help with prevention of that. So don't know if you want to answer that, or we go to the questions and they'll probably flow on.
Chair, before Claire or Kazim come in to answer, could I just make a quick procedural point? And I think Stephanie will correct me if I'm wrong, but I think it's because these slides have been presented at a public meeting in public. I think we're legally obliged under the Local Government Act to publish all the slides that were presented this morning. That's usually my understanding, isn't it?
Yeah, Jim, that's correct. I'll get a copy of them and upload them alongside the agenda.
So sorry about that, the niceties of procedure. I do apologise for interrupting.
No, that's absolutely fine. Okay, well, we'll come back to some of the things I said, but we've got lots of members' hands. Oh, sorry, Jim.
I wonder if, I don't know if Claire and Kazim would agree, but what I take this extremely helpful report as is a spur to action. And I think there's 3 strands. There's the immediate strand of our work to protect our very diverse BAME communities from COVID. And some of that is about the money we've invested in several projects already, and about the communications work and about the vaccines work. Then there is the kind of medium-term work about working with our BAME communities to understand more about issues and needs. And we've commissioned a development officer post, and we want to work on some detailed research about that, which David and Kazim and Claire will know more about. And then there's the longer term issue of how do we reduce inequalities in health outcomes in our BAME communities across both public health and NHS and council services. So I very much see this report as setting out an agenda of urgent work, but work that must continue for the next 10 years to address the inequalities in health in our population. I don't know if Claire or Kazim or David might want to come back on that and clarify my statement there.
It's Claire here, and yeah, thanks Jim for saying all of that. That's exactly our approach, really. We're very aware of the immediate need of work that needs to be done, as members are too, and the medium term, just having a strategy that works to reach in the medium term, and the longer term, it really does feel it's about reducing those structural inequalities, and which affect all different kinds of people, but I think looking at it through the lens of Black and Asian minority ethnic groups, it really shows the stark problems. But if we reduce those structural inequalities, then lots of people will benefit as well. And I think we need to bear that in mind. There are lots of people, as Kazim has said, through just the intersectional nature of issues, who are affected by health inequalities, and some more than others. And it is all different kinds of groups who are affected. So we need to look broadly in the longer term at all those structural issues.
That's lovely. And thank you very much for breaking it down, because I think that will help the panel in asking their questions as what can we do with this. So may I go to Ron first, please? And Kazim, is it possible to take away the presentation now so we can see the members again? That would be great. So Ron.
Thank you very much, Annie. Yeah, that's extremely interesting and important, Kazim, and I thank you for that. And is it possible? Have you got a point of contact for local members to get in touch with your section? Because it seems to me that I think most of us, well, certainly in the west of Hertfordshire, have minority communities of different sorts. I know in Hemel Hempstead we have a variety, and I just wondered what is available by language in terms of literature and other means of contacting these groups, and is it possible that there is someone we can contact for information as to what is happening in our own localities, and also what has been identified as the major issues, because certainly that would help us as councillors to actually get more address the issues more directly in our localities.
Shall I pick that up, Kazim? So I think, as Jim alluded to, we've got a development worker starting within our public health department, and there's already ongoing work aside from this study that Kazim has done on health inequalities, on racial issues, and that department is doing quite a bit of work already scoping what's needed and what's out there. So that would be probably our point of contact, and we can talk to them and see what work they're doing more locally on different districts.
Perhaps their details could be circulated to the to all of us so that we then have it available. Thank you.
Can I just come in on that, Claire? Because I think that's a really important point, that there's some fantastic work, that's fabulous work that's happening within offices, and quite often it's hard for members to know how to tap into it. So I think that's a really, really good point. If we can think about a way that actually there's more accessibility. I know at wards we have broken down, sometimes we have broken down reports of different wards and that sort of thing. It might be something that's at district level. So maybe there's something at county level that could be looked at different divisions with broken down further.
Okay, thank you.
Yeah, thank you. Nigel next, please.
Thank you. Excuse me. I've got first of all, just thank you for such a comprehensive report. I mean, I think it's a hugely useful resource for us to ponder on and work out what comes next, which is not as straightforward as I'm sure we'd all like it to be. I mean, my overriding conclusion from the report, and also discussing with Jim last week and previously on the BAME webinars that I've attended, I mean, we're not looking at a biological difference here. We are looking clearly at socio-economic deprivational issues, which our BAME communities are more exposed to than the rest of us. And therefore, we need to find a way of targeting resources more effectively. I think one of the things that I also found useful last year was, thank you to Margaret actually for this, was pointing me at the Marmot webinar that came from I can never remember the title of the organisation, Institute for Health Equity, I think it's called, which also highlighted some of the issues here and how important it is that we do make tackling health inequality an absolute priority. So that was my sort of comment overall. I had a very specific question, which is not really relevant to the overall thrust of this, but I just noticed on one of Kazim's slides on the mortality that asthma was very high up on the list. And I asked this because I'm married to an asthmatic who has become very confused about the level of risk and the difficulty of understanding the messages on asthma through the pandemic. And I do think it's worth mentioning, because I know there's a lot of us who are asthmatic or have friends or family who are asthmatic. And there seems to be a problem of messaging here. It is only the severely asthmatic, as I understand it, who are being prioritised in the government's rollout of vaccines. And there is a lot of evidence I've also seen suggesting that people getting asthma treatment are actually partially protected from COVID. I think there was a press release or paper out yesterday on that. So are at lesser risk. Just a plea, can we get the messaging more clear on this so that people understand their level of risk and also what's available to them?
Thank you, Nigel. I don't think that's a silly question at all, actually, because I think we go back to these early messages that seem to have disappeared and not been actually developed. Jim, did you want to say anything on the asthma issue?
I think it's a point very well made, and I wonder whether one of the easiest things to do, we have got a leaflet that's about to go out to everybody's house again about winter health. So if it hasn't already gone, I will just check. And that talks about COVID risk. I wonder whether we need to do, or perhaps commission a specific website. Our communications people will kill me for saying this because they're all working flat out, but there might be a company we can get a specific website for people with long-term conditions from, and there might be something we can get Asthma UK to do. So perhaps if I'm tasked to go away and take Nigel's suggestion and see if I can see lots of people nodding, Chair, yep. So that might be helpful.
Yes, please, Jim. Yep, we love giving you more work, and you've just offered another one as a potential workshop in the chat, and I think that would be absolutely brilliant. Those workshops to date have gone so well. Kazim and Claire and David, they've done the work, so it'd be lovely to share that with wider community. Just one question on that Nigel mentioned, and I'm not quite sure whether we've captured this, but since it's not so much biological reasons, can I just check with that, Kazim, that did we get that right, that diabetes is a seriously higher risk factor within the BAME community? So would that is that not a biological impact that's very serious and needs addressing and help with?
Yeah, so I mean, there was a report by the Government Race Disparity Unit where they sort of looked at all of this sort of thing, and they concluded that in the literature, genetics isn't one of the major risk factors driving this. Obviously, you know, there is a genetic sort of predisposition to diabetes and other conditions, but it's not the factor driving, you know, the higher COVID mortality and risk.
That surprises me. I thought we'd heard that diabetes makes a much higher risk, and that we've shown that the BAME community have a higher prevalence of diabetes. I'm not saying it's genetic. I mean, we might discover that's more lifestyle, but again, in our work in actually helping prevention, if that is proven, then it's something that we should be actually with our healthy hubs and whatever advising with. Sorry, Nigel, did you want to come in on that?
Not on that. I just wanted to clarify on the asthma question. I think the really important issue here is the definition of severe asthma and the different types of asthma. That's where I believe the confusion is arising amongst many suffering from the condition.
Okay, thank you for that clarification. Yeah. Okay, well, we'll carry on then. Lynn, please.
Thank you, Ali. Just to say, what brilliant presentation, Kasim, and Claire, your explanations. As someone who's a double hatter and a Welling Hatfield, sorry to bring it parochial, I was really surprised that Welling Hatfield do figure in the top 4 in the county for overcrowding, which I hadn't heard through other sources. So I just wondered, what work are we doing with the borough and district councils so that we do get a lot of joined up, because obviously housing is very much their bailiwick and we need to get that. The other bit is, I wouldn't have done the job that I did if I hadn't raised this. So it's semantics, but it's also about communication. I've noticed everywhere when we talk about older people, we say grandparents. And I just wanted to raise that the average age of being a grandparent is between 47 and 48. So I think it's going back. Are people just looking at the word grandparents? And it can lead to one of two things, either young grandparents, and the youngest one I came across was 32. Are they reading that and thinking, wow, I'm in line for vaccines, I'm in line for everything, blah, blah, blah. Or because we have younger grandparents, are they disregarding it because we are using that word to mean older people? And I just think it's worth chucking it in the mix that it's not a catch-all phrase. And don't forget, a lot of people now work to 70, so they don't see themselves as the grandparent. But I just thought you'd like to know that bit. Semantics, but it might be important in communication.
Yes, I don't know whether officers have anything to say on that. I have to say, Claire, we had a volunteer meeting for elderly people in St Albans once, and we hadn't realised there's at least 2 generations of elderly now. And so the ones that weren't good at lifting anything or whatever, because they were 90, and then there's 70 and even 50, so you're absolutely right. It's a very good point made. So thank you for that. And just Susie, in terms of biological, the other thing is that is the vitamin D element. I mean, I'm not sure. Kasim, was that something that you looked at in your report?
I didn't look at vitamin D specifically. But yeah, there's a lot of sort of papers on that, but I don't know if Claire or Jim want to comment on the vitamin D.
Claire or Jim, did you want to comment on vitamin D?
Only that there are a lot of papers about it, and it's a bit backwards and forwards and to and fro. People are not too sure of all the detail yet, so probably wouldn't have been appropriate to include it in the report at this stage.
No, but lovely. But going forward, that's something that actually is a good one to look at. So, sorry,
Ali, could I just ask about the answer to working with district councils? Are we working with them? Was the other question.
I can fill that one in, Chair, if you like. The short answer is yes, but there are probably multiple routes. So there's a whole kind of inequality strand that Claire is leading for us, and within that there's work on BAME populations. So I think we're going to have to kind of put that in the revision of the outbreak plan, as well as in the next public health strategy and a piece of work for the Public Health Board. But it's also going to have to go into the housing and the growth strategies. So I think there are multiple avenues for this that we're going to have to try and plug this into in order to resolve it. It's going to be a kind of a bit of a long haul, this, isn't it?
Thank you, Jim. Thank you, Lynn. May I have Margaret, please?
Sorry, microphone on. Yeah. Thank you, Chair. I thank you very much, Kasim, for a great report on underlying inequalities across Herts. I just wanted to see what else we could be doing to look at what really has happened in COVID to exacerbate the inequalities in health, because I'm very conscious, having had COVID, but also really worried about my mum who was at home, and I actually caught it while I was in Kent looking after her. What was really happening to the elderly with dementia at home, because the swab test is invalidated if somebody closes their mouth on the swab, and I'm not sure how much that was known when this data was collected, which is between the 2nd of March and the 29th of July. I have wondered how many people were tested at home and it was invalidated. They didn't realise quick enough that somebody really had COVID because it came out negative when it was really positive for people with dementia at home. I've sort of lived through this and, and asked, is it possible to do the lateral flow test? That you can take the test up somebody's nostril, and in the end that's what I did on my mum with an at-home test. But actually I've really worried about how many elderly at home were not diagnosed quick enough with COVID in that period, that this data has largely been analysed in the first lockdown. And so I'm quite interested in seeing the second lockdown and whether we're going to get data from the second lockdown, when I think we did learn a lot of lessons. And just to bring up just at this moment, and I know Jim knows about this, is access to vaccination for those that are housebound at home at the moment, when many GP practices are not necessarily doing home visits and putting in the infrastructure to be able to have vaccination for the elderly, which should be priority, but because they're at home, they're not able to drive to a vaccination centre and they haven't yet been vaccinated. And that being a priority at the moment to save lives. And then just on top of that is then noticing in the BA.
Oh, Margaret, I think your microphone has gone off.
Sorry. Is that better?
Yep. That's it. We didn't get the last point.
And lastly is just how many of the elderly in the BAME community are actually either living at home with their family, and then you've got the intergenerational risk of children giving them COVID, or even perhaps worse, when they're living on their own and are not able to necessarily tell people as quickly that they're ill. And so I've felt that within COVID, there have been factors exacerbating the inequalities in health, and why I particularly am interested in looking at the mortality rate, premature death, under 75 deaths, right across the community, but particularly in the BAME community, and whether we've done premature deaths, but looking at the other factors actually artificially made worse by the way we were doing testing for COVID.
Okay, can I go to say before Jim? Yes, I've got Jim coming in, and Jim, you might like to split these. A couple that are referred to this item, particularly the premature death under 75 BAME and the living at home. might like to answer that at this point, and then might want to take the home vaccination aspect with your next report, do you think?
Yeah, I mean, the short answer, Chair, is it's impossible to answer the question of how many older people, because we don't have that data. Nobody has that data. As we've said before, we didn't measure and test everybody during the early days, so all we have is the number of people who tested positive, and it's completely impossible to answer that, I'm afraid. As for the vaccine issues and inequalities, I'm happy to address them when it comes to my presentation, if that helps. I'm sorry, we just don't have that data.
Yeah.
Can I just say we could compare the death rate in the autumn, the second lockdown, to the first, because I don't remember being told that if you close your mouth on a swab, it invalidates the test, and that's what people with dementia do.
Chair, I don't think you are going to get any value at all, epidemiologically speaking, on deaths. Comparing the death rates will tell you about the numbers of people who die, obviously, in each lockdown. It will tell you nothing about whether people closed their mouths during swabs, for the simple reason that there may be multiple reasons for them dying. So one of the things we know at the minute is that oxygen starvation is a big issue. I'm afraid, Margaret, without commissioning a retrospective study of going around every single adult with dementia to see whether this has happened, it is impossible for us to tell this. And all we can do is improve. If it did happen, all we can do is improve clinical practice going forward. And there were lots of things done by clinicians in the early days where we didn't know. I mean, we ventilated people in ways that we wouldn't ventilate people now. I don't see how there is any population health gain to be had from going back and looking at that, when the thing we need to do now is change practice, if I'm honest.
Yeah, they're still not being tested, though, at home.
That's not true. I'm
can
sorry,
they be
no,
tested?
it's not true. I'm sorry. The home test kits are being offered to people. There are instructions on how to offer it, and there are multiple types of testing. And as we know, our strategy is not to test multiple people at home just because testing them at home. We test people with symptoms as well as offering asymptomatic testing. And there are nursing services, so our home care services, we can arrange for testing to go in and test people in their own homes where that is needed, or for the home test kits. And we know from the uptake of the home test kits that the uptake is very good. So I don't see that there is evidence for the assertion you're making, if I'm honest. If there is, please show it to me, and I'll do everything I can to improve it. But that's my my understanding of things as they currently are.
So the PCR test works on somebody with dementia who might shut their mouth on it at home?
That wasn't the question you asked, Margaret. The question you asked. Well, sorry. Let me finish.
Okay, we can talk outside.
Let's talk outside. But the question you asked was whether people are being tested at home. I think the issue you're raising of whether the PCR test is suitable for older people with dementia in their own home is a serious issue. But the test can be administered nasally.
Sorry, that was my point.
I will take that away and actually work with colleagues to see what we can do to make sure to identify whether this is an issue, and if it is an issue, do everything we can to resolve it. So rest assured, we when you last raised this at panel, we started working on it, and thank you for that very helpful reminder.
I mean, I thought about the saliva test, whether that could be developed for people with dementia at home.
I think they're not licensed yet for use, so we can't use something that hasn't been approved, unfortunately. But rest assured, I will keep working on this.
Yes,
thank you.
Thank you very much, Jim, for coming back on that. I am obviously taking in the chat regarding vitamin D in the chat, and I do think it is very important, and it's something that I'm sure in Hertfordshire we will be looking into as best we can, Jim. Yeah. I believe in it very much. I take it 3 times a day at the moment. There we are. Fiona next, please.
Thank you, and thank you for the very interesting and informative report. And going several steps back in the conversation, from what I've read from professional literature, people with severe asthma for this purpose are classed as those who've had a hospital admission through asthma or have had repeated short courses of steroids or oral systemic steroids or are on long-term systemic steroids for it. Hopefully that sort of clarified things a bit.
Yes. Yeah. Excellent. Does any officer want to comment, or?
I think that's very helpful.
Yeah, they're really, really helpful, as ever. Thank you.
And I think a number of members, so Fiona, Nigel and Margaret, have given us a few things to, and Susie on Vitamin D have given us a few things. Sorry, I've been frantically taking notes while people have been talking, so I do apologise.
No, that's absolutely fine. It's great. I think the panel are on fire today. It's coming at you from all directions, so capturing it is wonderful. And I don't think I've got any more members wishing to speak. So in terms of, obviously, I think we want to congratulate officers hugely on this report. We're backing you fully in terms of what to do with it next. And to have this evidence and to us to be able to work with it is wonderful. So we do need to vote on this item. Just to note the report, please, if you'd be able to do that. Thank you. Bye-bye, Caroline has to leave. Thank you. Okay, that's all. That's all noted. Thank you very much. So we move on to our sort of final update, which we've still got a couple there, which is obviously an update on COVID-19 response, which is so important to hear what's happening. So I'm going to hand over to Jim for this, please.
Thank you. And you've got a very short report in your notes, but the reason this tends to be done by presentation is because by the time it's written, it's already out of date. So obviously we'll give you our slides. Now I'm going to start by just talking about the epidemiology if my screen ever decides to share itself, which will be the really helpful thing. And I'm hoping you can all see that now.
Yes, we can.
Great.
Thank you.
So let me go to the context first. And so I can show you the bits I'm allowed to show you because some of this has secure links to other data. But if you look at where we are in Hertfordshire, you can see on the extreme left-hand side, actually, let me try this first is better. On the extreme left-hand side was the first peak in March of cases. And you can see that our cases significantly increased. And around October, we were fighting a number of outbreaks, as it were. And then our cases rose and then fell. But before we came out of the pre-Christmas lockdown, we already started to rise again. And that's very much due to the spread of the Kent variant, the B.1.1.17. And kept going up. Some of that may have been the demand for testing and have come down considerably, but they are still higher than where they were for most of the summer. And the rate of decrease may be slowing, but this was a massive wave, and it was seen across all age groups. It's also important to say that our positivity actually is still too high, although it may be, when I looked yesterday, it was around 8%. we want it to be below 5%, because the fact that positivity is around 8% still means, you know, that 1 in 11 people are still testing positive, and that means the virus is still circulating asymptomatically. The positivity in the early days isn't reliable because we were testing very few people and only those with symptoms. Now we are testing many, many more people, and the positivity is higher than we want it to be. And our testing rate, obviously, there was a massive spike before Christmas of people getting tested, and it has reduced. It is still higher than it was by some way and has gone back up again recently, partly due to the Broxbourne large testing exercise. So although you can see that our rates have come down, and you can see that this is the case across most age groups, different bits of the county are doing different things, and I won't go into detail on them because we genuinely will be here all day, and people will probably die of starvation before I stop talking. But just to take 3 of them, you can see there have been slightly different patterns in different age groups, but thankfully they are all declining. Now, there is no doubt that the lockdown is having a beneficial impact, but at the same time, we need people to continue self-isolating. We need people to keep on with the measures we want them to take, because deaths have not, plummeted and reduced. Sadly, we're still seeing people dying. Sadly, our hospitals are still very, very busy, and there will be a lag between cases coming down and deaths. And as we're seeing more variants with greater transmissibility, it's more important that we keep going with prevention. So we have to thank our residents for complying with the measures that have achieved this drop. But it's a case of we have to keep on going, because as we know, the vaccine is not yet proven to prevent transmission. We don't know that. So we have to do prevention measures as well, which brings me on to where we're at in the rest of our response. And I know we have elected member webinars coming up again, so I hope you'll forgive me if I don't go through in detail some of the material I do on the webinar for the sake of people's time. But if I can share my screen and the slides, so moving to the slides and to run through. So our epidemiology suggests that we're moving out of a massive wave. We're not out of the woods yet. It could easily turn if we don't take the measures we need to, and that means that we need to turn as a Health Protection Board to develop an exit plan, which I'm going to talk about in a second. I'm then going to cover the activities of the Health Protection Board, some work on self-isolation, surge testing, support for vaccination, and our public health strategy and recovery. And I hope I'm going to do that in 6 minutes flat. So our vision for the exit strategy is that the Health Protection Board, which is the board charged with the local outbreak plan, which is an officer board, creates the epidemiological conditions as much as possible for Hertfordshire to exit lockdown and stay out of lockdown in such a way that the journey to recovery can begin. Now that's ambitious, but we need to be ambitious. So our vision is that by summer 2020, we will have brought the virus transmission to the stage where we can begin the journey for recovery. And that means that we need to articulate how, for example, we get schools to operate safely in the new world, that we have sustainably low transmission rates of COVID. We may not get zero COVID, we'll be living with COVID for a while, but we should aim to get COVID as low as possible in its circulation for a prolonged period of time, so that we can begin to exit once and for all from repeated lockdowns. We hope that we intend to have a strong understanding of what works, and the early results from our self-isolation service have been really encouraging. We want a very high vaccine uptake, and we have models for how key sectors of our economy can reopen safely. And you know that we've done a significant amount of work on supermarkets, and we are negotiating with government to be able to do work on other areas of the economy as well. I won't go through all of these, but our residents have been really crucial to this. And so continuing to achieve a high level of population understanding of and compliance with key measures will be one thing we need to do. And the BAME work that has been presented today is just one strand of addressing the multiple impacts. So in terms of the activity, there have been a number of government grants to us, which I won't go through in detail, but in short, the money that we have, which is about 17 million for outbreak management, is intended to do a number of things. So there's targeted testing, contact tracing, communication, essentials for people in self-isolation, targeted intervention for specific sections of the local community and workplaces. So there are 3 BAME programs funded out of that already. We are expecting more. There are programs for transport and taxi drivers funded out of that, for example. We've also funded the voluntary sector community information champions, which I know some of you have kindly volunteered to be, promoting information about COVID and about the vaccines. We have funded environmental health officers, COVID marshals, a range of things. There's a huge programme of work going on. So there's a variety of things that we can use it. We've also funded support for rough sleepers so that they can be protected from the virus as well. So there is a national survey by the Society of County Treasurers, which is undertaken, and there are returns to government. And in essence, we have spent 12.5 million of our 17.5 million. So we still have some money left to keep us going until the summer. We've spent slightly more on testing than other areas of the country, and slightly more on contact tracing, and slightly more on self-isolation support. And that's entirely consistent with our plans to really make test, trace and isolate work as well as we can. And we will be spending more on self-isolation. We've had a self-isolation pathway in Hertfordshire that once you come out of contact tracing, and if we are having difficulty finding you or you're not complying, then we put in place support measures. And those measures include things like giving you help with shopping and medicine delivery, access to emotional support, all through Hearts Help. Also, we've invested £2 million in discretionary grants for people who just simply cannot afford, because of the nature of their employment. They may be 0 hours workers, and they won't eat, and they won't pay the bills, and they won't pay the rent if they have to self-isolate. So we know that most people who don't self-isolate because they can't, or they don't understand how to. It's a very, very, very small number that refuse to. And if I were to say to you that in our pilot programme on self-isolation service, we've had 173 people through the self-isolation pathway for enhanced support, only 5 of those needed any kind of enforcement measure. The rest responded to support measures in place, and I think that showed we were right to do this, and we're right to seek to expand this. We have spent a lot less on other areas, but that's because we want to be explicit about what we spend our money on. So we spent a fair amount of money on testing, a fair amount of money on contact tracing, and that has paid off for us. Additional environmental health officers, contact tracing call centre, people answer the phone more from our number than they do from national. We've spent money on compliance, which has been really helpful. We have a whole team who do nothing other than support schools in infection control. and a variety of other areas. And the additional grant money is about to flow, the £2 million, into supporting people to self-isolate. So that's the breakdown. We have a process for business cases that has to be gone through, and you're probably slightly less interested in this slide, so I'll skip past it and just cover some of the other arrangements. So test, trace and isolate have to be a core part of what we do going forward, and we are looking at that as we build our new plan. As you know, we've just completed 10,000 tests of people for the South African variant in the EN10 area of Hertfordshire, and our residents did an amazing job. I mean, we issued 10,000 tests. We've had nearly 10,000 tests back, and that's probably out of date. We aim to stop the exercise by tomorrow. In fact, we finished it all yesterday. There were 3 routes to testing. We, as yet, have not found any cases of the South African variant not linked to travel beyond the case that started the exercise off. We have identified 92 people who have tested positive, most of whom were asymptomatic. They are now self-isolating, and we wish them a speedy recovery. So that exercise has taught us a great deal about the use of testing for managing variants. We're also doing quite a lot of work on supporting vaccination. So by the end of this month, we will have done something like 50 webinars, seminars, question and answer sessions on vaccination. Every elected member should have received an information toolkit on how to answer questions from their constituents on vaccination. We did sessions with clinicians this morning. The County Council has a logistics cell that's supporting the rollout of staff and making sure vaccination centres are open, and in fact actually identifying sites and building them. But there is a big issue in uptake, and there is a big issue in inequalities, and a big issue in hesitancy we need to address if the NHS's job of putting the vaccine into people's arms is to work. That's taking a lot of energy and effort from us at the minute, and we're working on it. And then we have started the process of gathering together our next public health strategy and what we want to do on recovery. So a large amount of work going on. Just wanted to highlight some of that. Happy to answer any question you like, and indeed do a much fuller update for next panel if that helps. But hopefully that gives members a flavour of some of the 100 work streams that are going on.
Yeah. Thank you, amazing Jim. And I think the South African variant testing is something that is really important to us. And can I just check the cost of the surge testing? Was that down to us, or was there additional funding for that? Because that was in some areas.
There was additional funding for that, and we've done what we usually do, Chair, which is be as parsimonious as possible with funding to get the best outcomes. So we think that whole exercise will have cost us less than about 50,000 all told. Okay. But we had volunteers, because a bit of EN10 is in Essex and a bit's in East Herts. Volunteers, Broxbourne Council, East Herts Council, County Council, Fire Service and Trading Standards, Red Cross. I mean, you name it, we pulled in people from all over the place. And the logistics bit of it, which was managed by Taryn Pearson-Rose and Chris Bigland, was wonderful. The whole scientific testing end was managed by, we had Claire, who's on this call, we had Susan, who isn't on this call, we had David, we had a number of us leading on it, and a superb communications effort. We had nearly 500 residents on a call last Wednesday evening.
Yeah, and so just check, so if you found 92 cases, you're saying that they were only linked with incoming South African travel, is that what you're saying?
So the purpose of the exercise, but I should explain this more clearly than I did, I'm sorry. The purpose of the exercise was to identify whether there were any cases of the South African variant that were not linked to travel. because that's the concern, because it indicates community transmission. And we were one of what started as 8 local authorities and is now 15 local authorities around the country where cases were identified not linked to travel. And thankfully our resident is on the mend. I understand. I haven't met them, but that's the most important thing. And as yet, we haven't found a single case of the variant not linked to travel. Now, it could happen because we're still waiting on the results coming back. But at this point in time, we found 92 people infected with non-South African variants from this, 92 people infected from this exercise, of whom none so far have been found to have the South African variant. Now, that may well change as the lab results continue to come back, but that's where we're at present.
But many congratulations to the team for getting on down to it so efficiently and quickly, because it sounds like it's vital. Sorry, just before I go to the others, you had said you might capture Margaret's question in this part of your presentation.
The vaccination rollout has reached, I'll get the figures, but it has already done most people over 80 and most people over 75 and most residents of care homes. Home vaccination for housebound people is now underway. The NHS has agreed to pay GPs an extra £10 per dose for every house visit they make. The housebound vaccination is underway and GPs will go in and vaccinate people. And indeed, I had a query in this morning from a resident whose mother was visited yesterday because he was chasing it. So it is underway. I'm not in charge of vaccination process, but all roads seem to lead to public health. And every email I get from a resident is passed on to the NHS to ask them to action. But it is underway. It is taking time. It is very important, but vaccination of housebound people is well underway. I can see Louise is there, who may wish to say something more about this because she's closer to this than I am.
Do you want to come in?
Absolutely, thank you, Jim. I just want to give a little bit more detail to where we are with housebound patients. Now, actually, obviously, bearing in mind the NHS are leading this programme, so I am trying to work very closely with them and get as much detail from them as possible. But I am assured, and I'm told to be assured, that we have now, by the 15th of February, we will have offered and obviously vaccinated all housebound patients. So I think we just have to err on the side of caution in the sense that there might be some individuals that we don't know that are housebound. And I think in those situations, I think we need to encourage that those individuals contact their GP surgeries and make it known, or to any health services or care services they receive, and make it known that they're unable to get out to a vaccination centre. And then that GP surgery will ensure they will receive a vaccine in the house. But otherwise, we're in a very good position to have vaccinated them all by the 15th of February.
So they'd all be rushing to get their vaccine on Valentine's Day. I can see that.
Very true, very true.
So thank you very much. So may I have Nigel now, please?
Thank you. Sorry if I'm in the right button. Couple of things, Jim, on your presentation of the case rates, the graph that you put up there seemed to imply that 0 to 11s were the most affected currently. Is that correct, or was there an error in the legend?
So if I could get it, because if I could actually get my screen to share and show you,
While you're doing that, if I could maybe add another couple of questions.
Yeah.
So the other questions I had were, in the exit plan, what testing regime are you going to be recommending? And we've had various different proposals from the government over the last year. I would argue that it needs to be universal rather than symptoms only. We did have a moonshot promised, I think, at one point. Haven't heard much of that recently. But in order for TTI to be effective, what's your prescription on that? And the other question I had was on the vaccination side, once the 12 weeks is up, then unless there's a massive increase in availability of the vaccine, we're going to be spending all our time doing second vaccinations rather than first. What's the plan for that?
Thank you, Nigel.
Let me just note down the right. So hopefully you can see that.
Mm-hmm.
And you can see that the 0 to 11 and the 17 to 24 and the 40 to 59 are actually pretty much the same, as in fact are the 25 to 39. So they're more or less the same, which is a good indication of onward household transmission, actually. But I won't. I mean, David might correct me if I'm wrong there. So I was just showing the different rates for comparisons, but you can see they're pretty much the same in those age rates.
Okay, I think the reason I've sort of focused on that was because a lot of the talks only before Christmas was that 0 to 11s were relatively unaffected, and it may be that they are symptomatically unaffected, but also it goes to the question of the infection rates in schools, particularly in primary and nursery settings.
So I think you're raising two very important issues here. The first thing is, and they're both related to exit, I think. So the first question you asked was about the testing regime. So I think as we come out of this, it seems quite clear that PCR is really, really helpful for clinical diagnosis. It's very, very sensitive. Not a lot of use in large-scale population screening because it takes days to come back, and the issue is how we use rapid antigen testing to best availability. So I think we're going to see repeated testing of key workers continue for some time and repeated testing of others. From the data, and thank you to you and Ron for kindly sharing some stuff with me. The maths seem to work out that repeated testing of people using LTF in the right settings detects most people who are infectious in the infectious period, and that's a good tool. So ongoing testing of lots of the population is absolutely going to have to be a part of our strategy going forward, and I think everybody's doing that. And it's people like Louise, Claire, and Susan who've got the deep joy of working out what on earth that means, and interpreting that. So you're right. We have to do that. The other issues, to take the issues of schools and the under 11s, as we move out of lockdown, what does it mean to enable schools to operate absolutely as safely as possible and as low as possible? Now, I think our schools have done an amazing job. But what are the measures that will keep COVID as low as possible in schools, protect school teachers and others? And that's currently under national debate. But it is a vital thing that we need to have answered. So we're all kind of discussing that at the minute, because it's one plank, and I think schools, the advice of SAGE is schools should be last to shut and first to open. Well, that basically means we have to do a very strong piece of work around the epidemiology of how we get COVID absolutely as low as possible in schools and how we protect teachers and children as much as possible. And I think the playbook is still being written on that at the minute. So all I can say is absolutely agree with you. In terms of your third question on the next set of vaccine supply, that's all in the hands of the NHS, and that hasn't been shared with me or anybody else. So I don't know what their plan is, but they know that we're ready to help them when they need us. It's probably the only answer I can give you on that one.
Okay, I mean, it's a very obvious point that, you know, when we get to the end of the first 12 weeks, then rather than 300,000 per day or whatever it is currently, I think it's been higher than that. Almost the higher it gets now, the more difficult the problem becomes, because then you have to double it in order to keep going at the same rate.
Yeah. Very good point made. And it must be frustrating, Jim, to be slightly behind on knowing these things. So, as you're always asked, but there we are. NHS will come that way. Fiona, please.
Thank you, Annie. Vaccine hesitancy. What are we doing? What is HCC doing to reduce vaccine hesitancy?
So again, Louise may want to correct me, but we have a one-page vaccine uptake and barriers plan that is, and it's deliberately one page for the work stream. So there's a pile of stuff on logistics of helping people get buildings and things. Then there's a pile of stuff on educating people. So for example, we're doing a whole series of myth-busting webinars where any person working in social care can just join the webinar and ask any question they like. We've done, I think we'll have done, by the time we've finished this whole series, there'll be over 40 for elected members, social care staff. We're doing webinars for BAME populations. We did one this morning with the NHS. We were actually working with the NHS about working with their staff. We are recruiting vaccine information champions. Hearts Care Providers Association have a whole website of Q&As. Every elected member has received a vaccination information toolkit it went out on Tuesday or Wednesday from John Birch in the members briefing, and that can be shared publicly of things you can do. On top of that, we are recommending to the NHS the things that they can do to improve that. If you look at Watford have actually organised minibuses to transport people who haven't got, so elderly BAME residents who haven't got transport to get them to their vaccination. So there's a whole load of work already going on. I don't know if Louise wants to add anything. If there's extra stuff you think we can do, then we will put resource into it, because actually vaccination is I think test, trace and self-isolate for the minute are more important than vaccination in reducing COVID, but vaccination is crucial in reducing deaths. I don't know if Louise had anything to add there, Chair.
Yeah, thank you, Jim. I probably could just say a few words, actually. I think vaccine hesitancy is interesting, isn't it? Because there's a considerable number of reasons why someone might not want the vaccine. And that's because of, that could be because there's myths that are out there. It could be because of genuine reason due to their culture, that they don't want to have a vaccine. So at the moment, a lot of that myth dispelling and working with those different cultures has been happening within the hospital settings, because we've been really targeting those social and healthcare workers. A lot of that information has been quite broad in the form of communications, in the form of webinars. But what we are starting to do now is drill down to the detail and the exact reasons why someone isn't going forward for a vaccine. And what we are hoping to supplement with that is individualised one-to-one conversations to ensure that the person understands reasons behind these myths and how we can obviously counteract those myths. So that's the next piece of work that's currently ongoing with our health and social care workers. What you'll notice, Jim's kindly put in the chat the uptake of the COVID vaccine amongst the cohorts to date. And you'll notice uptake has really been generally quite good. Obviously, we're reaching quite easily the high 80s, sometimes in the 90s. But I think what we are going to find now, as we move down the cohorts, we are going to start to see less uptake of the vaccine as we reach the lower cohorts, the lower age groups, because they might not foresee that COVID is a risk to them. But obviously we need to encourage uptake, because we need to protect Hertfordshire and the residents within Hertfordshire. So what we have currently done now, we have set up an inequality working group within HCC, which is working with the NHS and all our partners, including the district councils and we are working up an action plan for each of our individual health inequality group. And within that, vaccine hesitancy is a prime component of it. And I hope by the end of February, we will have a plan of action to target all those vulnerable groups, and we will have a direction of travel in terms of dispelling those myths and ensuring uptake amongst our residents across all those vulnerable groups.
Louise, thank you. That's really comprehensive. Thank you very much, and good luck with that. Yeah, I think you're right as the age group comes down, but we'll see. Margaret, was your hand still up historically, or is there another question on this?
I think Jim sort of tried to cover the elderly at home. It was elderly housebound vaccination was one of them. The other one was really to do with teachers. I just wondered whether teachers have been made a priority yet, if the government plans for schools to go back on March the 8th. I am very conscious of the sort of debacle when some in London there was a mix-up and teachers started being vaccinated. And actually I did think that is the preparation we should really be doing for schools going back. It's the teachers that are the most vulnerable.
Jim, is that an NHS decision?
It's the vaccination decision doesn't sit with us at all, no. Unfortunately. It's an NHS decision and a central government decision. But I think lots of people are making representations about the things we need to do to make schools safe.
Do you know what priority group they are at the moment as a key worker?
That hasn't been set yet. That's we're in phase 1, which is the risk of people dying. So we're still working through phase 1, and teachers as a cohort of population have not been prioritised within phase 1 by the Joint Committee on Vaccination. And that's a national decision.
Yes. Okay. Thank you so much, and thank you very much. We've just gone over the 1 o'clock time, just tinily. So I'm sorry about that. But Jim, thank you very much. As ever. Oh, sorry, Ron. Yes, Ron. Cinderella.
Sorry, it's related to Jim's last answer. Sorry about that. Blame Jim. Yeah, there is an issue that is developing that I don't know whether Jim can help with. There is priority being given for teachers and staff who work with the SEND community and disabled to get vaccination earlier. I understand. I'm still catching up with this, but the educational support centres across the county, I believe there's about 10 of them or 9 of them, and I sit on the management committee of the Decorum one, are desperately trying to get the staff and teachers of the educational support centres put on the same priority list as those other teachers, simply because they do a similar pastoral job as well as a teaching job for excluded students of all ages, and they're now taking in primary school children as well as secondary school children. So I just wonder if there is any way we can influence that. You say it's a government decision on priorities, Jim, but is there any flexibility at all?
I think the short answer is those teachers in special schools or the staff in special schools were actually delivering personal close quarters social care. So they're doing things like washing, feeding, toileting, and a range of other things, and administering medications. The short answer is, with the cohort you're raising, I genuinely don't know, but if you want to take it up with me offline, I'm happy to look to see what government says.
Thank you very much, Jim, because it's the counsellors and the occupational therapists who work with these people, these students, as well as the teachers. And of course, some of those who deal with the young primary school, we are now getting excluded children of 4 and 5, believe it or not, and they of course take more. They of course have more personal contact than other students, and so it is an issue. I will continue offline, Jim, and I will send you an email. Thank you. Thank you for that.
Yes. Thank you for Ron. That's very important. Thank you, Jim, for taking that forward. And thank you again, as I said, for your presentation. And may I ask the members that are left to in the chat bar to show that they've noted the report, please. I think Michelle is organising this one. I think Stephanie's got a power cut, apparently. Lovely. Thank you, all of you. They're coming through noted. That's wonderful. And Louise, thank you for coming in there. So just finally, we've got number 8, which is the Future Work Programme. So I'm just inviting the panel to note the provisional agenda for the 11th of June, update of smoke-free policy implementation, then the Integrated Health and Wellbeing Service, then the Just Talk Com strategy, and then the whole systems obesity update. And obviously this is going to be after the election. So we don't know whom is going to be on this panel, but sorry, Ron, is your hand up for this item or is it still up?
I think that may be
I think Ron's become a pumpkin. I think he's yeah, whatever. So that's all noted by them. You don't have to vote on that, no, I don't believe.
I'm interested in this item. Sorry.
Oh, you are? Good.
Yeah. Sorry, I was muting myself.
What would you like to say, Ron?
Right, sorry about that. First of all, could I mention there has just been a statement by the government saying improving air quality was a top priority. We've committed to setting at least 2 ambitious new air quality targets. It's particularly relevant in Hemel Hempstead, as we've got 2 or 3 spots that are causing concern. But I just wonder whether or not air pollution should go up the priority list, Jim, bearing in mind we've just had the issue of the A10 junction, haven't we, in Broxbourne?
I mean, I think we're happy to take it away, and I mean, I don't know if Claire's still there, because I think Claire's leading on healthy places now, unless I've completely lost the plot. But we're happy to take that away and have a look at how we prioritise and what we prioritise.
Okay, fine. The other one that I had was to actually test Jim's crystal ball again with the government's announcement of their reorganisation of the NHS. But of course, because of the time and because it's actually quite an involved subject, I wonder perhaps whether we could ask Jim if he could give us his views on how the announcement may impact upon public health, and that could be given subsequently or added to the minutes.
I'm happy to send a written briefing, because the white paper, I think, and the NIHP raise a number of questions that I don't think we have clear answers to.
Yeah, that's my concern, and it would be useful, Jim, even if you could identify where the grey areas are, in which case those of us who are interested can then raise questions elsewhere.
Yeah, thank you, Jim.
It might be better as a phone call, as a call or whatever, Chair. But I'm happy to do that. And if it doesn't come quick enough, would somebody please nudge me?
Okay, thanks, Jim.
Yeah, lovely.
Thank you, Annie.
It's okay. It's a bit hard when it's released whilst we're during a panel meeting. So, but that's great, and I'm sure Tim will have a word with you, Jim, about actually the agenda for next time. So that would be splendid. So. I just have to say, is there any other business? Any other part 1 business? I can't see there is. The date of the next meeting is the 11th of June at 10 o'clock. So the officers will be here, I'm sure. We don't know who will be here. But that's splendid there. Thank you. Sorry, I don't think I needed to vote on the Future Work Programme, but thank you for noting it. That was very kind of you. So it just remains to thank you so much and to say what an amazing quality of scrutiny this panel actually conducted today. I think it's a real pleasure to hear the questions and to have the calibre of the officers who are able to answer them and move this work forward. So I'd like to thank you very much indeed and hope you have a good afternoon.
And thank you, Annie, for the way in which you chaired the meeting. And can I say best wishes to Tim, but he doesn't have to rush back because we've got you.
Like that. I'm going to get you out the meeting. We're going to shut you down, Ron.
Thank you, Annie, and well done.
Okay.
Yeah, thanks, Annie, and thanks, Jim and team.
Okay. Bye. Bye.
Bye,
Thanks, everyone. Bye.
Thank you.